We also have a note taker taking notes during this presentation, and we will get you those within about a week. If you experience any technical difficulties, you can leave and re-enter the meeting at any time with the Zoom link we provided. If you somehow lose access to the meeting, there will be an end survey that will pop up thinking that you are done with the meeting. If this happens mid-meeting, you can bypass that survey, re-enter, and the survey will pop up once the meeting has ended. If you have any tech issues, please let us know in the chat. As previously mentioned, there will be a short survey that will pop up on the screen after the meeting has ended. If you could complete that, we would sincerely appreciate it, as it helps us improve here at Concord Seminars. Again, thank you for joining us, and we'll go ahead and get started. It's all yours, Dr. Kohner.
Oh, all right, Michelle, thanks. And hello, welcome everybody. The other thing I'd like to add to the housekeeping that Michelle mentioned is that we are going to have dedicated time for Q&A through every section. We've got basically 3 sections in the morning, another short section in the afternoon, and then a longer one in the afternoon. And there'll be dedicated Q&A time. Lunch, by the way, is scheduled for 12:15 my time in Colorado, 12:15. I understand there's people from all time zones, so do the math on that one, 12:15 in Colorado. Let's see what else. All right, so I think that's my housekeeping. And let's go ahead and start. Let me just move my mouse. Here we go. I've been asked to make this point about the digital alterations, so I want to assure you that we're playing by the rules. What I have in mind for you today are, like I said, 3 separate sections. In the morning, we're going to talk about something that I'm fairly passionate about, and that is the ability to understand, diagnose, and properly manage periodontal disease. By the way, that number at the bottom of the screen, page 1, that does refer to the pages in your workbook, which I should mention, it's a little bit different. When I arranged the webinar, I made some changes over the live seminar, but I didn't change the workbook. So if some of the pages are off a little bit, that's the reason, is that we made some modifications to accommodate the online aspect. But basically all this stuff is still here. So we're going to start out with my take and my observations on the aspects of periodontal disease that you see up on the screen. And maintenance and patient compliance is a big thing. We're going to talk about that in the morning section, but also a very big part of that in the second afternoon section as well. After lunch, we're going to talk about soft tissue grafting, another aspect of periodontal disease that, if you are a restorative dentist or hygienist, if you're working in a restorative practice, we also think that this can be very directly related to you getting better restorative results. Hygienists, I'm sure you see people that mention recession around cuspids. Well, you're going to see what the options are for getting root coverage or not getting root coverage. And recession, if you're doing restorations, doctors, how you can prevent recession around a recently placed crown. So we're going to talk about all that. And what's really kind of interesting, I'm excited to share this with you. You talk about having literature in the presentation, evidence-based literature. So I have literature that I'm going to talk about throughout. That's a very important part for me. But I also have literature that showed up in my mailbox yesterday. It's a new article that I wrote. It's in Decisions for Dentistry. So it's called Decisions in Dentistry. It's a wonderful little journal. I've done programs for them before. And it just showed up yesterday. So I looked online on their website, and it isn't even posted online yet. So this is as current as the literature possibly gets. And you'll see that this afternoon, and I'll give you the reference to how you can find it. I'm pretty sure that when it goes online, you can download that article for free. And it relates to what we're going to be talking about in the soft tissue grafting area. After that, we're going to spend the bulk of the afternoon talking about managing periodontal disease in a minimally invasive manner with antimicrobial disinfection. Anthony, I know it's going to be a little redundant, is what we did the other night, but it'll be a great review. And if you have any questions, we'll be here to try to manage them for you as well. So the idea of the minimally invasive approach is that we're going to have a different focus of our attention. We're not going to just measure and treat pockets. I know we all do that. I know we all do, but we're going to have a little different approach to it. And I'm always excited to share that. We did that as a separate breakout the other night. So those are the 3 separate topics we're going to do to keep you occupied and engaged, hopefully, throughout the whole day. So let's start and see what we're going to do first. Diagnosis and treatment planning. I have a different look. I have a different take on this than traditional periodontal approaches. This is not Perio 101, by the way. So we're going to talk about inflammation and the relationship to bacteria and managing the bacteria. We're going to talk about how bleeding on probing is really a key parameter. But at the same time, I want you to understand, and we're going to talk about it in a bit, that a 5 millimeter measurement does not mean it's bad. I know that we're programmed to think that. Oh, you're probing 5, you got some 5s here, we better do some scaling, you might have to go get surgery, shame on you. But a 5 is not a 5. So I'm going to try to explain that and make some sense out of it. We're also going to talk about trauma. Does anybody have in your mind what I might say next? Trauma from occlusion. What's the role of trauma from occlusion? And hygienists, I know you may be thinking, oh, this sounds like doctor stuff. But I know you're here, and I believe that a large part of this relates to the afternoon part. All of it will. You're going to love it. But I don't want you to get discouraged. In the morning, I know it seems like doctor stuff, but I think it applies to all of us. So trauma from occlusion, very important. Bone is the key. Bone sets the tone. I know we talk about measuring pockets and soft tissue management and all that, but I want to show you why I think it's bone that we're really here to talk about. And then we're going to spend some time dealing with the elephant in the room, that no matter how great our therapy is, that if we can't get people on board to be compliant, then whatever we do is going to fail. So we're going to do our best to manage that. All right. So let's also, I said I think about things a little differently. Let's take a look at the first thing that I think differently about. When you think about home care, what are you thinking about? Well, home care to me could mean anything that's pictured here. Instead of home care, I would like to start talking today about PPC, otherwise known as personal plaque control. I think it's a good term. It makes sense, and we can talk about it and have the lingo, and it will give people some focus when they do go home. PPC should also be something reasonable and manageable. We sometimes get carried away with our PPC efforts. All these devices may be useful in the right instance, but I'm going to give you my take on a few of them and try to present something to you that I think is not only manageable, but simplified. That's sort of the key word for today. We're also going to take a look at why periodontal disease is so common. I think a big part of it is that it's due to something that's always present, bacteria. And even though we get rid of them today, they come back in the next day or two. So we're going to take a look at why this is so common, and I'm going to gear this to both groups, both hygienists and doctors. I think we'll find something related specifically to them that they're going to like. Now, periodontal disease is often looked at as the most common infection in the world. Here's an article that was the cover story. Let's see, my little pointer is working. Cover story in JADA last summer. I can't read that. 2018, so a year and a half ago. Cover story in JADA that a 5-year study done by the ADA showed that 42% of adults over the age of 30 had some form of periodontal disease. There are other studies that say it's even higher. There's some that go up to 80, 90%. So we know that it's prevalent. We know it's in all age groups. Why is it so prevalent? Well, I think the number one reason is that the bacteria that cause the disease are always present. And plaque control, now known as PPC, is sometimes difficult to get people to mechanically achieve. I was in a room once at a big dental meeting at a conference, And the speaker asked, how many people floss every day? And it was shocking in this ballroom of, several hundred people that well less than 10% of dental professionals flossed every day. So that gives you some idea about the obstacles involved. And so as a result, it's not really shocking to see that compliance among non-dental people, those folks we call patients, is not ideal for managing periodontal disease. Here's a large study published by a government agency. Over 8,000 adults were surveyed for this study. It was just published in the Perio Journal a few years ago. Prevalence of daily flossing among adults. In the U.S. during this time period, and they found only a third of the adults flossed every day. That's interesting. So you have to remember that. And I've said to people, sort of funny and embarrassing in a way, so do you use dental floss? Absolutely. I flossed today and actually for the last 2 days because I knew I was coming in here. Great. Okay. I got another surprise. Sometimes they only use it after they eat popcorn. Yep. That's true. That's what people have said. Oh, yeah, I use it after I eat popcorn. Not a bad idea, actually. So compliance is an issue. There's no doubt about it. But if we want to help people manage their periodontal disease, we have to make it clear to them that really it's on them more than it is on us. And this is a discussion that I have. That I'm not saying you want to have this one, but maybe you consider it. What I do is I explain to people that our treatment plan, whatever it is, whether it be scaling, surgery, implants, whatever, it could be 1 month, 2 months, 6 months, just a number, pick a number. So, for instance, the treatment might take 6 months. So people are very compliant during that 6 months. They come in, they pay their bills mostly for the most part, thankfully. And I explain to them that's the treatment. People tend to comply. But what's really going to make this work is not the treatment we do in 6 months. It's your lifetime commitment to managing and controlling this disease, because the bacteria that cause it are always there. And I try to explain to people in the light of diabetes, which most people understand can't be cured, but instead would be controlled by doing medicine, injections, things like that, insulin, et cetera. So I try to explain to them that this is a lifetime commitment. And I think that the literature which I'll show you, is very reassuring that if we can get people to accept and manage this and to be compliant, the literature does make it very clear that they'll be successful in managing their periodontal disease. So we have to get them motivated. They have to become the ones that are compliant. We're also going to talk this morning, and I touch on it again this afternoon, scaling and root planing. It's pretty commonly done. But is it helpful? No, I said show of hands. You see, I didn't change all my slides. Show of hands in a live audience, everybody would raise their hand because we're all programmed to do and rely on scaling and root planing. But I'm going to show you the limitations, and frankly, hygienists, you're going to be shocked at what the literature has told us about scaling and root planing. We'll go into it in detail in the afternoon, where the literature will tell you that it only improves the attachment level by 0.5 millimeter. Yeah, it's crazy. It's like, I almost can't believe it myself, but that's what people have published. We're going to also spend some time talking about pocket elimination surgery. And where does it come into play? Where do we want to use it? And is it helpful? It may not always be the answer. I'm actually going to present to you mostly this afternoon an alternative. Doesn't mean pocket elimination surgery is eliminated. Use the same word in the sentence is not good. Pocket elimination surgery has not been totally replaced, but it has limitations. So here's an example where pocket elimination surgery makes a big difference in the manageability of the tissue. So you can see here the probe score is somewhere around 5 or 6, and the tissue is very thick and bulky, and there's a big space in here. There's been some bone loss. I'll show it to you later, I think, I'm pretty sure. And after the surgery, has reshaped the tissue to have a minimal pocket depth, easily maintainable. And I'm going to explain to you where are the instances that this kind of procedure would be very useful, if not actually indicated, compared to where you might do methods other than pocket elimination surgery. So I'm going to touch on all that. We'll also touch a little bit on prognosis. For all of you, hygienists and doctors, with the sense that you can look at a situation and know that it has a hope for success or not. And Preston Miller is a renowned, revered periodontist in Tennessee. He's really made a lot of contributions to our profession, perio surgery, and also he's passionate about the idea of developing a way of looking at prognosis to know what we should treat and what we maybe should not treat. So in his article that was published not too long ago, when was it? 6 years ago in J. Perio, he and his colleagues stated that smoking had the most negative impact on periodontal disease. Look at that, 246% better chance of losing teeth. The reason for this is that smoking constricts small blood vessels. And what do you have in the mouth? Small blood vessels. You ever seen patients who smoke a lot that the palate is actually white? I've seen that many times, actually white. So smoking is a very big negative. It's interesting to me in the periodontal literature that there are still articles coming out that reinforce the idea that smoking is bad. I mean, we have like thousands of them, and yet people are still publishing articles saying that smoking is bad for periodontal health. Well, we kind of know that, and Preston put that in his article, puts it out there to remind us that if we're trying to figure out, should we treat you or should we not treat you, how much you smoke might matter. I remember one time I almost got tripped up in it. This guy told me he doesn't smoke that much, but I looked at his mouth and the palate was white. Well, I know that means he smokes 3 packs a day. So I said, I made the decision that I had to go by my gut feeling and not listen to him. And I said, I'm not going to do this. It was surgery for root coverage, connective tissue grafting, which has some technical challenges, and you need a good blood supply for it to heal. And I said, I'm not going to do it. He said, well, all right, I guess I have to be honest with you. I really smoke 3 packs a day. I mean, it's obvious sometimes. So be careful. When you see people like that, be careful. His second focus in the article was, oops, I'm sorry, I don't know if you see that. I accidentally brought down a menu. His second focus in the article was that molars, even with furcation involvements, last longer than we as a periodontal community used to think. And I agree with that 100%. Matter of fact, I will show you a few times today Bob's case where we treated him. He had already lost all his second molars. He had periodontal disease, loose teeth, occlusal problems, the whole thing. But he also had bone loss in the furcations of all 4 of his first molars. And here's an example of how, with the proper maintenance care that we're going to talk about today, I'm going to give you these tools and these ideas, these concepts. And he was compliant. So if he's compliant, as I said to you, we can have marvelous results. Here we are 19. Now it's 21 years later, I believe. I should check on this. The 3 first molars are all there despite obvious bone loss. I'm so sad to think that today this might have become titanium. But 20 years ago, Bob was compliant. The dentist was on board. Furcations last longer than we thought. That's what Preston Miller told us. So what do we learn from Preston's article? That smoking and molars, we can have a little different take on that. All molar involvement does not mean we have to take the tooth out. So as I said, I'm going to keep presenting a little different take on things. And that's the first part. Molars might last longer than you think. Also, we're pretty well conditioned to believe that periodontal surgery is very commonly needed. And it is, but it isn't. It's not the total answer. Maintenance and compliance are actually more important than the kind of surgery or even the fact that we do or don't do surgery. It's about compliance and maintenance care. So what's the problem with maintenance care? Well, people don't comply. They don't do as we suggest. And the literature, which I'll show you, does support that. So in managing periodontal disease, which we're here to talk about all morning, accept the fact that it's complex. I'm sure you all know that. Accept the fact that PPC is the key but we need to get people motivated to do that, which means we have to have a certain level of dedication and willingness to get up there and really show them in every way possible. And I'm going to show you this afternoon what I consider an unbelievably useful way to motivate and explain the importance of PPC and why they need to do it. So if we can get people to do these things, the literature tells us that we will have success. Now, here's an article that supports the fact of what I just said. It was an article published, it's 11 years by colleagues on the West Coast. All aspects of periodontal disease were discussed in this literature review, including treatment modalities, different treatments for periodontal disease. Now, before I tell you what they said, let me tell you that I trained for my perio at BU, Boston University. Down the street, 30 minutes on foot, maybe 30-minute walk, you get to Tufts Dental School. I did it recently. I was teaching at Tufts. I actually walked down to the BU campus, the medical center. About 30 minutes. So they're pretty close together. With the traffic in Boston, it might take 30 minutes to drive. But in any event, when I trained back there, we had this ongoing friendly rivalry because we had at BU Henry Goldman, and Irving Glickman was the head of perio at Tufts. And there was always this disagreement. You know, our method of treatment is better than yours. And there was an absolute fervent belief in that. Ours was better than theirs, and they thought theirs was better than ours. Goldman and Glickman did some exchange lectures. It was pretty nice to see that, but the rivalry continued. Well, this article talking about the treatment of periodontal diseases puts to rest that whole argument, because they concluded in their article that any treatment works. How about that? Hate to admit that. Any treatment works if the patients display good maintenance, care, and they come in regularly, and good PPC. Any treatment will work. So what is it? It's really about plaque and bacteria and compliance. So we're going to talk about that. I'm also going to talk a little bit about occlusion. Occlusion, we've been told, does not cause bone loss. So we shouldn't be too worried about occlusion. Or should we be? We're going to talk about occlusion this morning as well. And hygienists, I'm going to make some sense out of it. Also, we're going to talk about bone grafting. It's important, isn't it, to pick the right bone graft product? There's dozens and dozens and dozens of them out there. Does it matter which one we need? No, not really. It does not matter, in my opinion, what bone graft product we're using. And if you look at what's been used in periodontics, you might be shocked to find out that there was, until very recently, commercially available bone grafting material in the form of plaster of Paris. Look at, here's histology on new bone that's grown by putting plaster of Paris into a three-wall defect. So in case a three-wall defect is not clear, let me explain what it is. Bone loss here, no bone on the distal of this bicuspid. So the three walls are lingual wall, buccal wall, and proximal wall on at least one of the two teeth. That's a three-wall defect. If you give me a clean, clean it out, a distinct three-wall defect, I can grow bone in there with anything, plaster of Paris, or even nothing, even leaving it empty. I can get bone to grow in a three-wall defect. What's an even more, that's pretty predictable, but what's even more predictable, an extraction site? Why is that so predictable? Well, now we have four walls. That's why bone grows back in an extraction site. That's why any bone graft material you put in it will preserve the socket, because you've got containment. So it's more important to have the right shape of a lesion rather than agonize over what bone graft products use. What's another assumption we're going to challenge today? 3-month maintenance care, pretty standard, right? Does it work? Is there evidence that it does not work? Or is there evidence it does work? Well, it's pretty essential, but I'll show you later why it may not be the most important factor. But literature tells us that if people will follow the maintenance protocol, they will be successful. This is an article published by a colleague, periodontist, who is in private practice in Dallas, Texas. And he did a survey over 5 years of his patients in his practice, of people who paid him money, came in, it's like that business I showed earlier, the 6-month protocol. They went through the treatment, they paid for it, they completed treatment over a time period, and then he followed for 5 years to see who came back for maintenance care. And he found that not everybody did. The 1/3 of people who came in regularly, that were the compliant group, lost no teeth over 5 years. The other 2/3 were not as compliant. In that group, they lost 60 teeth compared to 0. Now, that's not the only article that I could show you in the literature that shows that maintenance care will help people keep teeth. But it's one of them that makes a lot of sense to me. So we're also going to, besides challenging your assumptions, trying to make sense of these variable, multiple decisions we have to make. I'm also going to spend time, more this afternoon than this morning, talking about a simplified approach that we can offer the patients regarding PPC. So I think, wouldn't it be nice if we could no longer tell people that they need to floss, no longer harass them that they're not flossing enough? Well, I'll show you this afternoon the use of these little interdental brushes, which I have in my pocket. I mean, I have 2 different sizes. I think they're really, really useful. And they can, in a lot of instances, replace flossing. So it's easier. People love it. Okay, so we'll talk about that in great detail. Also, we're going to spend some time, I think hygienists, you might like this idea. Doctors too. I think everybody should like this. Some of you may or may not have heard of Bob Barkley. In the 1960s, the late 60s, probably before most or all of you were born, Bob Barkley traveled the country. He was a country boy, I think from farm country somewhere, honestly right now I can't remember where, and he went around schools and conferences. You're not going to believe it. He was talking to us all over the country about how we need to teach people to do better plaque control, how we need to teach people to brush and floss. That was his passion. He traveled the country, and he taught us about his 5-day, he called it disease control program. I might call it plaque control program. Even in our discussion, we'll call it plaque control program. And he charged them to come in and paid him to teach them how to use a toothbrush. It's important. He's the one that popularized flossing back in the 60s. So it's good. It works. There's no doubt about it. But, I'm going to show you a simplified approach today that might even be a step better. It doesn't mean people shouldn't do plaque control. They have to. We'll go over that. So Bob Barkley was very passionate about this. And while he pissed off some people and he made some people think it was a bad idea because they didn't quite get on board with the program, this absolutely was his gift to dentistry. And it was sad that he died prematurely in a plane crash after he had made such a difference for so many of us. And his conclusion was that communicating with people about this all-important aspect of PPC was the absolute key to success. And this is what he said, quote, "Dentistry is a behavioral, not a clinical science." You know what? I think he's right. And I've tried to practice that ever since. Now, here's an example of a way that his disease control program can be so meaningful to people. Blake was in his 30s, young guy. He comes in. He's got all this inflammation around the teeth, calculus on the teeth. And hygienists, I know you are just itching to get your Cavitron on there. I know you are. I know you would like to get a Cavitron on there and knock all that stuff off. But if you could resist it and say, Blake, This is a toothbrush. This is how you use it. Let me show you. And come back in a day or 2 or 3 or 5, and let's evaluate the results. And when Blake comes back, it might, well, it shouldn't be, but it might be surprising to him that all his inflammation is gone. So what we've just explained to Blake is that he's the master of his disease, not us. Because if you took all that calculus off and he came back in 5 days, he'd say, great job, thank you so much. You took such good care of me. But he would have failed to learn the lesson that it's really the bacteria that was causing this inflammation. So after he comes back a time or two and we coach him and help him and improve his plaque control, then you can take the stuff off the teeth. And now the tissue looks just great, even with a little bit left behind. So now you can do it without bleeding and soreness and tissue irritation, because most of the disease is under control by the plaque control. So that's what we learned from Bob Barkley, how to manage plaque control programs. Now, as I mentioned to you, Preston Miller talked about trying to predict which teeth could be treated and which can't be. And he showed us that the molars maybe will do better than we thought they would do. So you have to be careful in trying to predict what's going to work and what's not going to work. So the Perio Academy, in their infinite wisdom, came up with their recent efforts to have new nomenclature and different classifications for periodontal disease. It's complex, it's cumbersome. It is being taught in the dental schools, which is good, because then maybe that group of people will understand it and be able to use it. But it's been challenging for a lot of people in practice. It has not been widely accepted by the periodontal community. The founders of it insist that it was not meant to change anything we do, but to better explain what's there so we can make sense of a treatment approach based on different categories. Well, I think that treatment is more fluid than that. We can't just take a number, a category, and say the category X is treated with Y. I think it doesn't work well that way. And so it's not been widely accepted by the perio community. But I just want you to know that what they're trying to help us to understand, as if we don't already, right, is that people with gingivitis with the proper flossing and brushing, they can return to health and be pretty much on their own. But people, once they've developed periodontitis, the proponents of this classification say, they're trying to get us to understand, as if we didn't already, and if I didn't already talk about this earlier this morning, that periodontal disease leads to periodontal patients for life. So it does. It requires SPT, is supportive periodontal treatment or therapy or something. That's what they're trying to get us to accept, which we already kind of know. So if you're using this or trying to use this new classification, don't be too frustrated, because a lot of people are. So just know the perio community looks at it as being awkward to use. But it's out there, and I couldn't not address it. So if we're going to treat people and we want the results to be predictable, then, and this is where I'm talking about a thought process, there is a lot of things to choose from. There is a long list of things to choose from. So that makes it kind of tricky. There are minimally invasive approaches, and we're going to talk about it in detail this afternoon. My take on minimally invasive approaches, sometimes surgically minimal invasive surgery, or non-surgical treatment, hygienists. I'll show you cases managed completely by my hygienist that resolve periodontal disease. So we have minimally invasive approaches and we have surgical approaches. We're going to talk about them. We're going to talk about flaps and bone surgery. I'm going to show you that you may look at root amputations as being old-fashioned and so 1970s, but I'm going to show you that it isn't. It's actually useful. It's a way of managing with a form of periodontal disease. We're also going to talk about bone grafting. And I've already mentioned how I think the bone graft product that you choose is not the end-all and the be-all. And you already know, because we already talked about it, and Bob Barkley and the lifetime model, that none of these treatment methods will work or matter if people are not compliant and we can't get them on board with their role in it all. So you see, I'm beginning to try to point things out from a little different perspective. Not just do surgery, not just do scaling root planing. There's more parameters, there's more layers that we have to deal with. And look, I'm here as a specialist talking to probably mostly general dentists, because that's typically who comes to the lectures and to the workshops that I used to do. Someday, hopefully, we'll be out doing live hands-on workshops again. But I believe it's okay to teach this to the general dentist community, because I think that you have the opportunity to be the quarterback in managing people's care. So it takes a team, but you could be in charge of the team. I know that we periodontists think we're in charge, and that doesn't always work. So as an example, I show these race car drivers. So take a look at the guy in red. He is sitting here looking around for help, and there isn't any way he can compete with the guy in yellow. The guy in yellow with the whole pit crew, they can pull in, change all 4 tires, put gas in the car, and he's back on the track in under 9 seconds. The guy in red by himself can't compete. So if you're out there by yourselves, doctors, and you're not working as part of a team, I think you're handicapping yourself. I think you can learn through lectures and workshops to do some of these perio procedures yourselves, but the end of the day is you don't have to and shouldn't need to do every single thing that comes across your desk. So work as a team. I think that everybody benefits, especially the patient. So that's the overview of what I have in mind. Okay, so those are the things that I said we were going to talk about. So let's go through them now. Let's go through each one. Go to each one in a little bit more detail. So let's talk about plaque control. I said we were going to talk about it. But I also want to point out to you the fact that I believe that plaque control is not the answer. We have to be aware of the fact that there are some limitations that we might have to overcome. So I'm opposing that as the answer, because you might have people that have physical limitations, like this guy with a big tongue, or that's a toothbrush that a patient brought into the office one time. And because we ask people, let's see what you're doing, and they bring in their toothbrushes, and you can't have good results with that. So there's more to plaque control than just plaque control techniques. How about this little tufted end brush? If we were live, I would ask you all to raise your hands and tell me how many people like them, recommend them, or maybe even use them. Because I used to think that this was like great. And I can't tell you how often we would dispense this to patients with this little tufted brush and say, you got a bone loss in your furcation. You just take that brush and squiggle it around there. And that's what you do to control your plaque. But what happened was, I can't remember now, 5, 6, 8 years ago, maybe more. I was having my teeth cleaned by the hygienist that had worked for me for like 15 years. And I've had, I don't know why, I have perfect bone. If you look at my x-rays, perfect bone interproximally. But my gums have somehow managed to shrink down a little bit. So I've exposed some roots and I've exposed some furcations on the buccal and a little bit on one lower lingual where the furcations are exposed. And she was telling me that that's always where there would be calculus trapped. So she said, here, try one of these. Sure, why not? I've been dispensing these for a long time. So I take it home. I tried to use it. And you know what? I couldn't use it. I could use it maybe down here. I could see well enough to use it here. But anywhere else, it was really hard to hold my lips, see what I'm doing. If I can't see it, how are we going to expect patients to see it? Now, I've said this in live larger meetings, and people say, oh, I love it. It works great. Well, that's good. But if I'm having trouble with it, I can assure you that there will be some patients who are going to struggle with it as well. So I showed that slide earlier about how complex PPC can become. So just be aware. Plaque control this way may not be the answer. Also, plaque control may not be the answer if we have certain anatomical limitations. All right, how many times, probably not very often, have you come across a lingual groove or on the lower first molars an enamel projection? I mean, I've come across them. It's not never, but it's not real common. But the fact is, if you don't pick up on this, people are going to fail at their plaque control efforts. If we misdiagnose, people are going to fail at their plaque control efforts. Joanne's story is extremely interesting. She comes to me and says, 5 years ago, I had these 2 crowns made. And ever since then, my gums have been sore and red. And my hygienist and my dentist tell me I'm not flossing enough. So you see, it's not all about flossing and brushing. And for 5 years, she said, I've been trying, but it doesn't work. So she mentions this gum problem to her friend who says, if you got a gum problem, go to my guy. She comes to me, I'm her guy. And it doesn't take long to diagnose the fact. You can probe with a little anesthetic in here and feel that these crown margins are almost touching the bone. So they have gone into the tissue and violated what you see right here, the biologic width. So this is a biologic width violation of impingement. And I explain that to people by taking their hands and putting my fingernail under their cuticle and showing them how impingement occurs, soft tissue to hard tissue, and the crown digging into the attachment is sometimes painful, hers was not, or sometimes irritating, hers was, in causing this inflammation. So the minute I explained that to her, she was ticked off at the dentist and hygienist as well. And it was a sad scenario to witness, but we were able to help her by moving the gum and bone away from the edge of the crowns. So again, it's not all about flossing. There's more to it. There's making the right diagnosis. And there's also motivation and education. Now, I know this is almost gross and hard to believe, but this is Samuel's mouth when he first presented to me. Now, he was a fascinatingly interesting guy. He always came in with a suit. He had this lovely little old leather briefcase, a very sophisticated gentleman. But he didn't know how to brush his teeth. And the only reason he came in is because his wife made him come in because he had bad breath. So now, again, hygienists, I know you just want to get the Cavitron on this thing, but Bob Barkley would counsel us against that. He said, this is an educational process. So I did the same thing. Samuel, here, this is a toothbrush. This is how you use it. Go home and work on it and come back in a few days. And Samuel comes back in a few days, and a week, 10 days maybe, notice how the gum here is already starting to shrink, even though all the calculus is still on the roots. But what's important is he's learned to get the plaque off the teeth and the tissues start to heal. So after that lesson and his understanding that he's in charge of this, now we can get all the deposits off. Today, you might say, oh, it's a reconstruction case, but, he was just delighted to get rid of his bad breath. And we didn't do any definitive treatment, but we helped him and we educated him, and he became very compliant and maintained his teeth for a long, long time. So there are some exceptions to scaling and root planing, and it's a little tricky. And I'm going to try to make some sense out of it. So Harry, who we're going to look at extensively this afternoon, is the example. If we're going to do scaling and root planing by quadrants in a mouth like Harry's, because we're trained to do it by quadrants, that might not work so well because we might clear out one quadrant and it would be difficult, soreness, bleeding, etc., and maybe not even be effective because there's so much calculus. But we're going to have 3 other quadrants. We're going to try to reinfect the first one. So if you know that you're going to do something like this, sort of like with Samuel too, you don't do it quadrant by quadrant. You do it all at once. Now in his case, because there was such severity of bone loss, we did it with an open flap approach to get everything off the teeth all at once. And we're going to go into Harry's case again in detail this afternoon, but look at getting that stuff out of there, how the body responded with healing new bone. So we're going to go into his case this afternoon. But think about the fact that quadrant scaling can be counterproductive. That's what we'll talk about later. So I'm still talking about the rationale against plaque control. Scaling root planing by itself is not the answer without the education, motivation, and illustration. It's not just even doing any of these modalities, because then we're up against the systemic issues, smoking, diabetes, and the long-term challenges. So the key is for our patients that they should try to be brought along to understand that, like diabetes, there's no cure for this, but again, it's their compliance. We've got to give them PPC modalities that are easier to do, that they might then be more compliant. And one of them, I'm a really big believer in these interdental brushes. That floss, because of the limitations it has anyways, is not the answer, forgetting if people would do it or not. But you can see here how floss, if there's been some recession, it hangs up on the convexities and doesn't get into the concavities. You know, in my mouth, I've experienced some of that with the recession. I don't know why I have, but the little interdental brushes are fantastic. The company whose brush I really, really like, it comes in like, I think 15 different sizes, maybe even more, 15 or more sizes. But you see, there are limitations to dental floss, even if people do it into these concavities. It's very, very limiting. And the dental literature, while not loaded with articles on interdental brushing, is starting to catch up. Here's one that just appeared in your RDH magazine earlier this year by a colleague over in Northern Europe. And she writes about, this is the title of it, the role of interdental cleaning for oral health, general health. You know, a lot of people talk about the systemic factors. And she pointed out, citing 3 different review articles, that all stated, she tells us, that interdental brushes are more effective than floss. Well, yeah, I just showed you why with all the concavities, et cetera. And besides that, they might also be more effective because it's easier for people to do. I can keep this in my pocket. I can use it anytime I want. Well, my wife says not anytime, but you know, you get what I'm saying. That Anna writes that these brushes are, according to her review of the literature, more effective than flossing. So give it some thought. I have to think about this. You know, I have to double check, Michelle. There's a workbook. Oh, yeah, you know, I think then there were some handout pages, but I think they're part of the workbook, so it's all one handout. I don't have any way to check that, Michelle. Maybe you can figure that out for me. Because
I did send over the presentation that you had sent to Robin in the chat. So everybody does have that in the chat, as long as, and it was also emailed with the agenda.
Yeah, I just have to check if at the end of the workbook, if there is also a 5 or 6 page separate handout. I think there is as part of the workbook. So we'll have to figure that out.
Let me take a look while you finish up.
Yeah, it would be at the end. Okay, so once we find this additional handout, the reason that it came to my mind now is that it does give you some sources for some of the products we're going to discuss, including these little brushes. So it will be in the handout one way or another. We'll figure it out. All right, so that's my argument for why we can't rely totally on just plaque control. We can't rely on just teaching people how to do it because there's just too many obstacles and too many limitations. On the other hand, On the other hand, I want to argue for plaque control because it is, in essence, the foundation to everything we're doing, but it doesn't happen without our focus and our motivation that we're going to educate people. We see patients come in with a wide variety of periodontal issues. And to just knock this stuff off the teeth is not the answer, in my opinion. Now, the literature does guide us in knowing how important it is to control the plaque. I'm not saying that plaque control and bacteria aren't the key. They are. But just thinking that we can teach people how to do it is not the answer. So the literature, we'll go back to the classic periodontal literature of the 1960s, where Harold Lowe, who was director of the NID, National Institute of Dental Research here in the States, did his classic study on experimental gingivitis. I believe they used the dental students over there in the Scandinavian part of the world, and they had them stop brushing. When they stopped brushing, Harold Lowe found after 3 weeks that gingivitis had developed. We're not shocked, right? The bacteria are left untouched for 3 weeks. So gingivitis develops. And then what happens? Then he starts people back on brushing, and it only took 1 week to return to health. So their conclusion was that there's a direct connection between plaque and gingivitis. It occurred, it went away. He said plaque and periodontitis, they can't prove it that easily, but they believe it's got to be connected. I mean, this is what they said in 1965. I think today nobody would debate that. But also at about the same time in the 1970s, Hans Werhag in Norway, the Scandinavian part of the world gives us so much good research. He showed us that actually if there is plaque above the gum line, that's going to contribute to more plaque growth under the gum line. So you see here, even in health, plaque can start to work its way underneath and it eats away at the bone until things get worse. He then argued, stated, claimed back in the 70s that the chance for patients to completely remove subgingival plaque was really only fair once the depth became 3 to 5 millimeters. It was pretty good, less than 3. But once you get over 3, it now became difficult to remove the plaque, and they would fail and develop disease once they hit that. Maybe this is where the magic 5 millimeters came from. Maybe, I don't know. But greater than 5 millimeters, you're going to have disease. You can't get the plaque out. Makes sense, right? We could easily believe that. And it probably is true. But I'm here today to show you that there are alternatives. There are ways to efficiently, effectively, and simply remove the plaque subgingivally. I say simply because I've even changed my thought process since I started talking about this topic. What if there was a way where we could get at the plaque by simply using a water irrigator with some chemical disinfectant in it, or even, how about this? Do you like this even better? Just rinsing with the proper chemical disinfection. Wouldn't that be great? Well, the literature today is totally supporting this approach. I mean, for a long, long time in practice, I told people that irrigating was the way to do it because they can drive this solution under the gum and kill the plaque. And that's why I said to you, every 5 millimeter probe score isn't equal, because we can manage these. So wouldn't it be nice if there was some secret agent available that wasn't too expensive and was readily available? Well, I know Anthony already knows what the answer is, but sometimes in a large lecture hall, people know the answer to this. Well, there is such a solution, and you can buy it in your nearby grocery store, and that solution is Clorox. It's a disinfectant. If any of you have swimming pools, I bet you have chlorine tablets in your pools because it kills bacteria. So I'm going to show you, especially this afternoon, how we can manage plaque control and plaque disinfecting by using very dilute, just a few drops of Clorox really in the office, and kill the bacteria, just like people do at their swimming pools. And I'll talk about it in detail this afternoon. So if we can kill the bacteria, and then we could more simply get rid of the plaque in between the teeth without nagging people about flossing, I think we'd be well ahead of the curve. So you see, this is not my new rationale. I talked to you why I didn't think plaque control was the complete modality that was going to solve problems. Well, I just showed you why it wasn't, but now I showed you why it is. So plaque control is important. We're trying to get people to be more compliant, and if we can simplify it, then maybe they'll be more compliant. And we can convince them, as you saw with Tom Wilson's study of his own patients, if we could get them to come in regularly, then maybe they'll be in this group of 1/3 of his patients that didn't lose any teeth, because compliance works, plaque control works. We just have to find a way to deliver it to people that they can do it. So there's lots of articles in the literature. I mean, I'm not going to bore you with tons of them, but here's just one other example. Again, done in the Scandinavian part of the world, the Clinical Perio Journal, long-term maintenance of patients that have already been treated, same as Tom Wilson's protocol, already been treated. They had perio maintenance every 3 to 6 months. And in this part of the world, I think that care is socialized, so people have no reason not to comply. And so people come in regularly. And what they found was that less than 1% of this group, and I forget how many people were in the group, but it was a substantial number, less than 1% had any periodontal disease greater than 6 millimeters. Some 90-some% of the sites in all these mouths managed to maintain periodontal scores less than 4 millimeters. 14 years if they come in regularly. It works. So just like we saw with Tom Wilson, we can get people, if we can get people to comply, there will be success. Now, I'm still talking about the rationale for teaching plaque control. It's very important to teach people these lessons. And here's an example of a 14-year-old girl. Now, maybe there were some hormonal issues, but there was also deposits on all of her teeth. And we did the same Bob Barkley motivation. All right, Valerie, this is a toothbrush. This is how you use it. Go home. Come back in a few days, we'll check it. But this is your treatment for now. So she goes home, she works on it, she comes back 1 month later, no treatment, no calculus removal. The deposits are still on the teeth, and she's able to get that kind of healing. So plaque control is really important in the right perspective, the right mindset. Now, after we get this deposits off the teeth, look at how the tissue responds. Look at even between the centrals, the tissue grew back. So yes, there's my argument against plaque control. There's my argument for plaque control. So there you have my initial crazy thoughts. What can I tell you? So it is now, let's see, number 49. 9:10, 9:35. Okay, so I'm going to take a look now. See what I tell you, Michelle, around 9:30, right? Ah, yes. Oh, I'm hurt. I'm disappointed. There's only one question here. Oh, Anthony. Hi, Anthony. I don't know what, let's see. That looks like they have nice thick tissue. If they also have thin tissue with a lot of puffiness, would you do scaling and replating first? Which case could Anthony be referring to? Maybe the two cases that I showed where they just started with the toothbrush. If that's what you mean, Anthony, then I would say, yeah, I stand by that. I mean, if they had thin tissue, it might be even more important. Maybe even more important to get people on a toothbrush first and see how much shrinkage they get so we don't have to do any scaling into, invasiveness into and under this very thin tissue. I think that if there's no plaque, there's no disease. You know, there's a guy out somewhere around Montreal, somewhere in Quebec, Canada, who they just teach people how to do oral hygiene and put chemicals under the tissue. And they don't even do any scaling, root planing, Anthony, I think for, I'm sorry, I don't remember the number, 3 months or maybe even 6 months. Because he said there's nothing more important than training people to do this themselves. So yeah, don't try to overthink these things, because the bacteria is the key thing. That's the only question I see for now, folks. So I am going to stop again. Later, there'll be more opportunities. You come up with questions. And as Michelle said, if you come up with some burning issue, you can raise your hand. I don't know if I'm going to see you raise your hand or if she is. But in any event, happy to make as much sense out of this as I possibly can. So there you go. I had more time set aside for questions. But maybe you'll come up with some questions at the break, and we'll answer them before we get started again. So at this point, every time I do this, let's see. I'm going to suggest that, what time is it? 9:37 my time, that we take a break for about 12 minutes, brings us to 10 till 9:50 my time. Or do we, any reason want to go longer? We'll go longer later. How's that? So we're going to stop now. Let's call it 9:40. Let's go to 15 minutes. 9:55. 5 minutes before the hour. 5 minutes before the hour, I'm going to start back. Okay, Michelle?
That sounds great. I'm just going to go ahead and launch that first poll. So if everybody, you're going to see that pop up. If you don't see it, look behind your browser. And if you still don't see it, you can just message me in the chat so I can make sure you get credit for attendance. Okay, so we'll go on break, you said, till 9:55.
5 minutes before the hour. Absolutely.
Perfect.
If you have questions, just put them up during the break, and I'll catch them when we come back. Thanks.
Enjoy your break.
All right, so I see the timer on the poll is counting down, just counted down 15 minutes. So I presume that that's the same 15 minutes we were talking about. So I've got one more minute on my watch, and then we'll start back with the next section.
Perfect. I'm just waiting for a couple more responses on the poll, and then we can go ahead. Not a problem.
Well, I think we'll start. Hopefully they respond, but I think we'll start when we start.
Okay. And I did take a look at your handout for the presentation, and I do show that it looks like the last 5 pages, there is some information and resource sheets. I'm
Yeah,
not sure
that's
if
it.
that's what you were talking about.
Good. I had a feeling. I guess I should make a note about that. Okay.
Yeah, it is on there, and there's even a section where they can apply their letterhead.
Yeah, that's good. Okay.
Perfect. All right, I'm going to go ahead and I'm going to end that poll, and you are set to go whenever.
Okay, wonderful. Thanks, Michelle. Thanks, everybody. I've got 5 minutes before the hour here in Colorado. I think it's probably 5 minutes before the hour wherever you are, but I won't guess what the hour is. Let me take a quick look at the questions. So it's interesting. I never know this when there's a lack of questions. I never know, and I say this at live seminars too, and every group is so different, that I never know if it's because things are very clear and you don't need to ask any questions, or because I completely confuse you to the point of oblivion and you don't even know what to ask. So, I mean, this happens and it's okay. But the good news is I'll stop again after this next section if more questions come to mind. And then let me see. Then we'll have, maybe before lunch, there'll be time. So there's always going to be time. We're doing very well as far as staying on time. So I'm ready for your questions when you come up with it. Oh, now I got to figure out how to move ahead. All right, so the basic principles that I said that I wanted to talk about, we talked about plaque control, PPC, the rationale for it and against it, and why it really is the cornerstone anyway. So we could argue against it, but we still need to figure out a way to get it accomplished. The next principle that I'll talk about is the trauma from occlusion concept. So hygienists, you might feel like this doesn't apply to you as much. This is maybe more geared to the doctors. And it is to a degree, but I think that also there's going to be something important here relative to the potential for recession around certain, usually maxillary cuspids and first bicuspids that can easily be suffering trauma from the occlusion that leads to recession. So you should have a sense of that. And I think that trauma from occlusion is a really key factor, key foundation to managing teeth. So the Journal of Clinical Perio, this was a number of years ago, 80, it'd be exactly 40 years ago. Colleagues at the University of Michigan, they've always been very geared towards occlusal concepts. And again, they have a very different approach to managing periodontal disease that I never really accepted or understood. But now in light of the Armitage-Robinson study that I showed you from the West Coast, that they said any treatment works if maintenance and plaque control efforts are good. Well, that validates the work they do at the University of Michigan as well. So this is a particular study on, you can see the title, tooth mobility and how it relates to the results of periodontal therapy. They followed a number of surgical patients for 8 years, and they found that, no surprise really, but it's good to have these things validated, that mobile teeth did not heal as well as teeth that are solid. So there's a rationale established here to do occlusal management. Here's another study from the same school. A trial of occlusal adjustment in treating periodontal issues. 50 patients, occlusal adjustment before treatment, whether the treatment was in this article, surgery or scaling was used, different treatments, it wasn't all the same treatment. 2 years later, they found that the group that had had the occlusal adjustments done had gained more new attachment level than the teeth that had not, which kind of says that teeth that are moving around don't respond as well. Now, let me give you a really, I think interesting, kind of fascinating take on what happens with periodontal issues, whether the teeth are moving or not isn't even the issue. So we're going to look at germ-free animal studies. These were the classic studies done in the middle 1970s at the Eastman Clinic in Rochester, New York, on monkeys. There were 4 studies. The first 3, these are monkeys that are raised without any bacteria in their systems. What they found is that they created trauma from the bite. The teeth did move around and ended up with bone loss. But then when they took away the trauma, so they did this with like putting crowns on the teeth that were traumatic in nature. So when they removed these crowns, that the bone grew back. Now, it's my opinion, I could be Wrong. It's my opinion that it's from these studies that the profession has learned and that students are taught that occlusion, trauma from occlusion, does not cause bone loss. So therefore, you in practice shouldn't have to worry about trauma from the occlusion. I thought that was kind of interesting, but it changes in their fourth study. In their fourth study, they added bacteria to the picture. So now when there were bacteria added in to these germ-free monkeys, guess what happened? Now when they caused trauma to the teeth and bone loss developed, not a surprise, it didn't grow back. So now the question then becomes, this is an easy series of articles to relate to clinical practice because I don't know about you, but I've never seen people that are germ-free. So if the patients that we treat have bacteria, then the first three studies don't matter, do they? All that matters is that we should learn to accept that if there is trauma from the occlusion, in the right situation, people can suffer with bone loss and it doesn't grow back. Now we have to treat it. So that's a classic study. But there's also a similar study, but different, also very well respected by colleagues from Baylor in Texas and Boston University, where they took a look at, read the title, The Effect of Occlusal Disharmonies in Periodontitis, the Relationship of Treatment to the Progression of Periodontal Disease. So you see what happened in the Michigan studies when they did occlusal therapy, they had better healing. So what happens in this study? 90 patients, 24-year follow-up. Occlusal adjustment slowed the progression of bone loss. I mean, it makes sense, doesn't it? Well, this is how I was taught in school. This is the book that I had in dental school, authored by Norm Arnold and Buddy Frumker. And they had some cute illustrations in the book, and they make the point that teeth can handle up and down forces. The periodontal ligament is a spring that holds these teeth up, and you can press down on them, but the ligament holds it, gives it a little give even to accept the trauma. But teeth don't do well, and the bone around it doesn't do well when they have horizontal movement. So now that would explain why you're probing around hygienists, you're probing around, and you're probing 3s and 2s and 4s, and even 5s, you know, like I showed you, 5s don't worry me that much. Boom, bingo, you got an 8 or a 9. And in this case, there's nothing to see on the x-ray. What could be going on? So if you're probing and you find one big area and the x-ray tells you nothing, no information from the x-ray, let's try to analyze what could be going on. What I'm trying to get you to think about now, moving forward, is that possibly it's, will this go backwards? It's very possibly this, that we've got horizontal occlusal forces. So let's look. Do we have horizontal forces? Well, we put some ribbon in there, and hygienists, you can put your finger on these teeth too, and have people tap up and down, wiggle side to side, rub side to side. And you will feel this tooth moving side to side. It's not a shocker. There's trauma from the occlusion that relates to this. So now, if you could open up the area, you would not be surprised to find bone loss around that isolated tooth because of trauma from the occlusion. And notice the difference here. Let me go back again. Notice here that there's contacts of the lower opposing tooth on the inner incline of the upper lingual cusp and the inner incline of the upper buccal cusp. So at different times in different jaw movements, this tooth is getting pushed forward and backward. What we would prefer to have would be contact only in the central fossa, disclusion being handled by the cuspid, and this tooth could have a chance to heal. Now, it's not going to grow back bone. It's not going to grow back that bone, but it will allow for treatment of that bone loss. So if you were going to put a bone graft in there, and that's about as good as any lesion to do bone grafting, it's a contained 3-wall lesion where we have wraparound. So we have a buccal wall here and a buccal wall here under the arrow. You can't really see it. But this, you could easily put bone into this trough and it'll grow bone every time if the teeth aren't moving around anymore. So if the teeth are moving around, then you're just not going to have the results that you would expect, that you would want. So there's a question, Anthony popped the question in here. Any thoughts on the tech scan digital bite analysis? I think T-scan, right? That's what it's called, T-scan. Yeah, I've seen those. I've seen people use them. I have no objection to it. I know somebody who's a Pankey trained guy, very into occlusion, and I've been in his office and watched him use it. So I think that it can give you information. All we're looking for is a way to guide the creation of stable occlusal contacts, Anthony. So that means that this helps by showing you where there's more pressure on one tooth that you maybe can't tell visually. Because, I mean, you look at these markings, they're pretty gross, not gross, obnoxious, but they're gross compared to the definitive fine results you see from the tech scan. So yeah, if you use it and you are familiar with it and you're able to get information from it, I don't object. I never used it. I'm a big believer in managing the occlusion and wearing mouth guards, which I'm going to cover in this section as well. But the T-scan is just another tool. Remember the Armitage study. Any treatment works. I'm not being negative about the T-scan. Any treatment works if you have good maintenance and good plaque control. So that's another tool, another golf in the golf bag, Anthony. Thanks for asking. Oh, every time I do that, I have to change this. All right, so now it's sometimes tricky to figure out trauma from the occlusion. And I want to point out the fact that if you try to wiggle teeth with your fingers, that you're not going to get reliable results because your fingers are gushy and soft. Instead, I find I could use one fingernail and one instrument. So I have two hard surfaces wiggling a tooth to test mobility. This example shows two hard surfaces, either one with instruments. So two instruments or one fingernail, one instrument helps. It's useful to try to figure this out to substantiate when you find something. So like you saw with that maxillary bicuspid, that there, well, I didn't show you the x-ray, but there was nothing to see on the x-ray. Here, we'll take a look at the x-ray, same patient. If you're probing around, you might find all of a sudden that there's a big probe depth, like right here. See the pus drainage? A little bit of pus drainage, but there's nothing on the x-ray to give you even a hint. So you have to go purely by your examination. And then once you say, well, something's going on here, what could it be? Maybe it's the occlusion. So I want you to think about it. Then you can mark the tooth and you will find, look at that, and lo and behold, a balancing side contact. Balancing side, for those who might not be familiar with the term. Watch my jaw. If I'm sliding my jaw to my right side, the left side over here is the balancing side. The right side is the discluding side. The left side is the balancing side. In occlusal concepts, the balancing side contacts are very destructive because the brain doesn't like them, and they have us clench and grind and gnash around on these balancing side contacts. So you can see in Elaine's case, there's completely clear PA, but a big probe score on the buccal with pus drainage, and it's substantiated by finding the balancing side contact. So you know something's going on. And when you then do the surgery, doctors, or refer it out, whoever does the surgery is not going to be shocked to find the bone loss because you had every sign of it. Balancing site contact, big probe score, not a surprise. But you can't manage the bone graft without the occlusal contact therapy to relieve the pressure, all right? So the bone graft wouldn't solve the problem without controlling the forces. Now, what about areas of recession? Same principle, same exact principle. Sue was referred simply, she and I laughed about this for a long time, simply for a little treatment of her recession. But it didn't take long for me in the examination process to notice that the cuspids were worn out. There was no point to the cuspids. First bicuspid, same thing. These teeth have been grinding and bruxing. This cuspid has been opposed to the cuspid in the opposite arch many, many times. And I've been grinding on this and working on it and working on wiggling these teeth. So that treatment of the recession, just like treatment of Elaine's bone loss, won't be successful without managing the occlusion. So there's the concept again, horizontal forces. So if we put some ribbon in, we notice that there is more force on the first bicuspid to create the discluding guidance than there is on the cuspid. So this first bicuspid is the same as this first bicuspid. And that's why from the wiggling side to side, as you see from Norman Buddy's book, wiggling side to side beats up on the thin bone of the socket and destroys the bone. So can we do bone grafting there? No, there's no three-wall defect. But we should be able to do some therapy to cover up the root if we stop the tooth from wiggling. So that's why, hygienists, you can diagnose this, you can identify it, you can know that there's potential for root coverage, but you also should know and be able to even discuss with the patient that something has to be done with the occlusion. So notice that after occlusal adjustment photo, there's less pressure on the first bicuspid, more pressure, which you can tell here by this clear line, that would be a halo of the opposing tooth touching there, and that's the discluding factor now, instead of the first bicuspid being the discluding factor. So there's no way that you can treat this recession without stopping the wiggling. Now, what about the concept of splinting teeth to control trauma from the occlusion? Well, here's an example that the ancient Egyptians understood the need and the benefit of splinting teeth from a mummy. From the Goldman and Cohen periodontal text that we learned from, the big thick book, they explained splinting in this manner. If these teeth are all equally mobile, then splinting them together does not prevent movement from forces moving buccal to lingual. If one tooth is loose, you can splint it to the adjacent teeth. But if all of them are loose, movement buccal to lingual won't be controlled. In that instance, they explain how we need to splint around the arch. So now we have stability, tripodization, so that the teeth that are in different directions will help to stabilize other teeth. So splinting has been something that's been fascinating to me for many, many years. And we trained back in the 70s that we used a lot of splinting. Today, people probably take out teeth and do implants, and I don't necessarily agree with that, by the way. So I'm going to show you cases to substantiate what I just said. But this is interesting. I know you're going to laugh at me, but the perio journal has always been green. I mean, I saved the perio journals for all these decades since I trained. In my garage, I had all these metal shelves and perio journals lined up. And when we moved to Denver, my wife said, "This is enough of that. Goodbye to all the journals." And it was really painful to throw them away. But I mean, I know rationally that they're all available online now. So if I need something, I can find it faster than going out to the garage. But I saved these 3 orange clinical perio journals. These were my favorites. They're still sitting in my garage here. But they said some fascinating things. Again, colleagues in the Scandinavian part of the world did evaluations back in the 70s and 80s. Look at the titles of these articles. The role of occlusion for the stability of fixed bridges in patients with reduced perio support. You'll see, you won't believe how much reduced support there is. Another article followed up later on mostly the same cohort of patients, the capacity of reduced periodontal tissues, in other words, very little bone, to support fixed bridge work. And here's a picture from their article. Look at how few teeth there are and how much bone loss there is. So this tooth, even with no bone around it, once it's splinted, that's the fence post idea, the wiggling side to side that you saw in the Arnold Frumker book before. The fence post wiggling is controlled. You see, I'm going to darken the screen. Don't think something just happened. If that's what I explain to patients, is about the fence post. If your tooth is like a fence post, if it's in the ground and it wiggles, then there's going to be a trough of dirt around it. And that'll continue to wiggle until you somehow splint it to other fence posts. And when you do that, the wind and the rain will fill in the trough. All right, here is the perfect example of exactly that, the fence post theory. Notice that tooth with a lot of bone loss, and you can even see the trough around it. And notice here, once it's been included in the splint, the trough fills in. Look at the trough fills in. Very small troughs here, but down here it's pretty well filled in. So they showed over 300 bridges followed 8 to 11 years. None of them were lost. There were no perio problems because, again, people came in for regular maintenance care, probably socialized, no reason for people not to come in. Regular care, no bridges were lost, and there were no further perio issues because they were able to stabilize the teeth. So I'm convinced. I'm a believer. Well, that brings us back to Bob, who's maxillary, I think it was the maxillary molar x-rays I showed you earlier. Bob came in, he's in his 50s, he has trauma from the occlusion and resulted mobility of his teeth. He's a bruxer, and see, he's lost all his second molars, probably from trauma. He has pockets, well, he's got bone loss and all the frications, all 4 molars. What are we going to do? Well, if you want to save the teeth, you got to stop the movement. So we're back to the controlling the horizontal forces. His treatment was an orthotic. Now, I differentiate an orthotic from a night guard. It's the same piece of plastic, but it's used differently. An orthotic I use by having people wear it 24/7, and I see them every couple of weeks. And as their jaw settles and the muscles relax, the movement occurs and you can see the occlusal markings change, and you keep adjusting it until the shifting stops, and they come in 2 or 3 times in a row, and the mandible is stable and the marks are consistent from time to time. So that's the idea of controlling trauma with the fence post idea. So he wears the orthotic. Wait, let me back up. He wears the orthotic for 3 to 6 months until the jaw stops shifting around. Then we equilibrate to let the teeth start stabilizing. Then we do whatever perio is necessary, and then the splinting, because these teeth remained loose. Pocket elimination is done, and it says definitive, except sort of, because the molars couldn't be definitive. So he's going to do a big restorative job. It's going to help to splint his teeth. So what are we going to do about the bone loss and the frications? Are we going to extract these teeth because they have frications and they can't be treated? Well, there is an article which we're going to look at more later on today, and that's the title of it. It was an editorial in the Journal of Dental Research a few years ago, and the title is, well, you can read it for yourself. Should we strive to save teeth? Well, you know what? I'm going to read it to you now because it's relevant to Bob's molars. So here's the article. It was just one page, and this is what it says. A trend affecting clinical practice over the last 2 decades. And when was this written? This was written 4 years ago. So a trend over the past 2 decades has been the reduced emphasis to save compromised teeth. As such, many teeth are being condemned at early stages, given the expediency that lends itself to quickly get rid of a problem tooth and provide a replacement implant. Then they go on to say, this is their words, not mine, the erroneous belief of implants yield a better long-term prognosis has now clearly been rejected in several studies and reviews. And on the second page, they list 12 or 15 studies, and this was 4 years ago. Since then, there have been dozens more studies showing us that the success rate of implants is really not as good as we thought or were led to believe back in the 80s when this first was descended upon us. So the reviews are showing that implants yielding a better long-term prognosis isn't totally true. And then they go on to say teeth, even compromised because of perio or endo, may have a, quote, longevity, this is their words, that surpasses by far that of the average implant. So there you go. It's pretty interesting to me because I think that today somebody might look at these molars and say, well, you're better off to remove these molars because we can't treat those frications. So see, that's my point, is that this was 20 years ago, as I showed you earlier, 20 years ago, and those teeth are doing just fine because he's compliant. So that's his treatment. We're going to manage these teeth. We're going to control the occlusal forces. He's going to wear the orthotic to get his jaw relaxed, equilibrate, splinting, and then he's going to wear a night guard for the rest of his life, just as I do, and just as my family does. I mean, I really, really believe in mouth guards. So we've got to control the movement, the horizontal movement, to create stability. And what I want you to see about this particular guard is notice little dot, 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 dot contact. They're just cusp tip contact. Should have the ability to slide around on it. The anterior in red has disclusion. The posterior is just cusp to acrylic contact. So what's happened here? Well, now it's been over 20 years, and these molars, all 4 of them are still there. Notice how the bone is densing up. Notice he's got some fuzziness in the bone interproximally, and now that that's because of the movement, and now that we've controlled the occlusion by equilibration and then ultimately splinting, we can stabilize them, and the dirt around the fence post settles in and grows around the teeth. And the mandibular molars, same thing, 20 years now. Bone loss, and by the way, I know this is a no-no among speakers. It's a no-no to say, we're going to talk about that later. And I know I've already said it 2 or 3 times, but we're going to talk about this later. So I apologize for a no-no, but this is a clinical journey, and I can't get everything in there at the same time. But these teeth can be maintained beautifully with water pick irrigation, beautifully. And Bob's been compliant. So occlusal therapy is what makes the maintenance therapy work. I think I just added this picture. This is my night guard because I just did a little work on it, a little adjustment, and we marked it. And there you see again, dot, 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 dot. No big, heavy incline contacts, just nice cusp tips to plastic. Yeah, that's mine. Just put this in there a couple of weeks ago. So Bob's therapy worked because we got a reduction in the trauma. We controlled the fence post. We got compliance from him. Without it, it wouldn't work. And when I say properly adjusted night guards, it's that there's no horizontal contacts, freedom to slide around, anterior disclusion. And that's how that frication is doing well 20 years. Now, what I like for the irrigation on these frications is the water pick or the Viajet. They both come with special tips for getting into narrow places. The water pick has these little rubber nipples. The Viajet has little metal irrigators that will get subgingivally. And Bob's been using it with the dilute bleach that I mentioned earlier that we'll get into in the detail this afternoon. See, I said it again. I apologize. To maintain these frications. Oh, now here's what you do not ever want to do. You don't ever want to open these frications up so that people can get interdental brushes in there because they're susceptible to decay. We can do well with delivering the antimicrobial Clorox subgingivally. And here you see essentially 20 years later, all 4 molars are there and doing well. And I have to tell you something else. When I got these x-rays from the dentist, Kevin, 3 years ago, he said, I have to tell you, I really didn't believe this treatment could work. He said, but I put my faith in you, meaning me, and he went along with it. And he was so excited to show me the 20-year x-rays when I stopped in there 3 years ago. But he didn't believe it in the beginning. So you may be sitting there thinking, yeah, this is ridiculous. It can't work. This is one case. This is just one example. But we've done this with lots and lots of people. Maintenance care works. The Wilson study, the Scandinavian studies, maintenance care works if you can get people on board. As far as night guards, they've changed some of the codes on the night guard just recently. They changed the codes. I don't agree with using soft appliances ever. That triggers the brain to want to do more grinding. I also don't understand what a partial arch night guard would do, because if all the teeth aren't in contact, then the ones that aren't in contact could tend to shift, I think. I mean, I don't know the rationale. I've never done anything but a hard mouth guard. And look, I mean, I show you the codes and I tell you that you have to do a narrative to tell the insurance companies why you're using them. But, you know, the coverage is so minimal, I wouldn't get hung up on it. Basically, somebody just said this to me yesterday. The lady at the bank just said to me yesterday, well, I referred her to a dentist here in town because she's got some severe TMJ issues. And she said, well, I'll go in January. My insurance is going to kick in then. And I just said, no, it's not going to matter. Insurance won't cover this stuff. And she said, oh, okay. But this right up front, it's not going to help. All right, so we're still talking about splinting. Ralph Pollock is a colleague who's also been very into this concept. And he has recently been doing presentations. I would love to see him present this at some of the conferences where I've gone, where he shows a 40-year retrospective of people that have maintained their teeth by splinting. And just one of them that he sent to me to share was done back in the 70s, where he developed this splinting technique when he worked with Henry Goldman, who I mentioned was the founder of our school. So this is back in the 70s. This lady had lots of bone loss. You can see all the exposed roots, tooth loss, of course, trauma from occlusion just because of lack of posterior teeth. And here she is all these years later with all the teeth still there, new camera. Look at the difference in the camera, with the teeth splinted together. And again, I don't think that this could work without splinting the teeth. So it's pretty rudimentary, but you don't need fancy crown and bridge. So here's the bone, 1973, same tooth. Look at how the bone is healed. There's a certain amount of bone present, and years later, it's really pretty much the same. Bone loss has not progressed. Here, if anything, it's healed, and this tooth is gone. But the mesial and the bicuspid, angular bone loss, it's all healed. That's the trough around the fence post. It's healed because the teeth stopped moving around. Ralph published his findings at 25 years in Dental Clinics of North America, if any of you have that around. So splinting is very powerful. Now, another aspect of controlling trauma from occlusion is that of having proper occlusal curves. So here's an article I published also many years ago in the 1990s, showing way to manage the occlusion by using implants and crown lengthening. So Dave, this guy's name was Dave. He didn't wear his partial denture. And once implants became recognized, he shows up wanting implants to give him some teeth back here because he said he hates his removable partial. Well, you can see the occlusal challenge by these erupted teeth. So not only can we provide teeth back here, but we must provide some alteration in the occlusal curves, the curve of Spee. And we did that with crown lengthening to make these teeth longer to allow the restoring dentist to then make them shorter and put them into the curve of Spee. Here's a case to illustrate the exact process. Bonnie's got the same deal. Many of these people did not wear their partials and the teeth erupted. Now that they know about implants, that's where they want to go. You can see the eruption. You can see what the wax up is showing with the potential for correcting the curve of Spee. So we have these long teeth that are over erupted. Temporaries are made. We can take the temporary provisional crowns off to see how much tooth we're dealing with. And we can then do crown lengthening to expose more of these teeth, again for the purpose of shortening the teeth into the curve of Spee. And you can see the difference. The teeth here are drooping down low. Here they've been shortened and restored. And now there's room for the curve of Spee to be handled with the implants, but only because we could move the teeth out of the way. So all of this has to fall under the auspices of controlling trauma from the occlusion. Otherwise, we wouldn't have a long-lasting result. So I think all the treatment planning we've been talking about this morning are all separate little aspects of managing people's mouths. Occlusion, however, is extremely basic. It's extremely foundational. It's extremely important. And as we learned from the germ-free animals, as soon as they added bacteria into the monkeys, they had bone loss. So occlusion has all kinds of factors, TMJ factors, trauma, moving the teeth around factors. We looked at the studies that we saw that when they manage the occlusion, they have healing better. So I'm not suggesting that this course will in any means teach you anything about occlusion other than to make you aware of it and the importance of it. So I say go study somewhere. Where have I been exposed to it? Well, I think John Coyce is a true visionary. He's one of the smartest, best teachers of dentistry today. And he's out on the West Coast in the Seattle area and teaches his occlusion course. His quote occlusion course almost has nothing to do with equilibration and managing the way teeth come together. It's just a whole different mindset. He's brilliant. But occlusion, just like I showed with Bonnie, that's occlusion to shorten those teeth. So John Coyce, also for me, I was very lucky that I went to the Pankey Institute down in Florida, somewhere within my first 3 or 4 years of being in practice. Wow, that was unbelievable. So this is Dr. Pankey's cross of dentistry. He says, if you know yourself and what your temperament is and what you want to do and try to achieve, you know your patient. You know, he has this famous list of 21 questions to ask the patient what they want. And you know your work, which is kind of what we're talking about today to talk about different aspects of treatment. And if you know these things, apply your knowledge to treat people, you will be rewarded not only materially, but spiritually as well. He believed that very strongly. So I was lucky enough when I first went to the Institute to hear him teach this course on his philosophy. Well, look at what I experienced. This is what got me so focused in on occlusion. So I was suffering from TMJ issues in high school, college, and even in dental school. I could not chew a steak. If I tried to chew anything that tough, my jaw hurt. I didn't know what was going on. So when I was in dental school and also in my perio training at Boston, in both instances, I was friendly with and liked the instructors who taught us the occlusion. Well, Norm Arnold, the one that wrote the Green Book. They both equilibrated me at dental school and at BU. They both equilibrated me, didn't change anything. My jaw still hurt. I still ground my teeth like crazy. I can remember waking up, my teeth are stuck together. I opened my jaw, grinding so bad. You look at my teeth now, they're all flat. I go to the Pankey Institute, and in those days, they were taking TMJ x-rays on everybody in the class. I never saw a TMJ x-ray before, ever. I was already through dental school, through my perio training, never saw a TMJ x-ray. So this is what mine looked like, and I didn't understand it. So here's the joint, here's the condyle, and notice that it's very close to the glenoid fossa, very close, very small space. And on the other side, the left side, there was a bigger space between the condyle and the fossa. Now, knowing nothing about this, I went to Henry Tanner, one of the instructors, and I said, I don't understand this, but shouldn't they at least be equal? It's exactly what I said to him. He says, oh my God, sure. And I'm not exaggerating. In like 8 seconds, he jiggled my jaw. He showed it. There it is. You're only hitting on the left side. You have a huge gap on the right side. Now picture this. Picture standing up in mismatched shoes. We'll say, well, yesterday I was at the bank and I said to Suzanne, she had high heels on. I said, picture standing with one high heel and one sneaker. Your body would be tilted. How long would it take walking around like that until your hips or your knees or your back started to ache? She said, not very long. So what happens here, because this was long term, don't forget, high school, college, dental school, training, years and years, what happens is the body wants to get both feet equally on the ground. So the fact that the left side had a tooth contact, the right side didn't, the muscles pulled my jaw up on the right side, resulting in that different appearance of the x-ray. So Henry Tanner, and I was lucky, there were a bunch of us that went down there to the Institute together, including somebody from my building. So we went back, we put me on an orthotic that I wore for, who knows, 3 to 6 months. And then we couldn't equilibrate me because as my jaw evened out in my head, orthopedically, the right side had a huge gap. So what we did was we did gold onlays to make the teeth come together. So now I got both feet on the floor with 2 equal size heels on my shoes. And guess what happened to the pain? Gone. No, it was gone when I was wearing the orthotic. Gone. So once we did that, we had to build up the teeth. And now we take another x-ray and you can see basically equal space between the condyle and the fossa. So I became impressed with occlusion as a result of this. It changed my life. It changed the way I practice for sure. It allowed me to save a lot of teeth just from equilibration, manage a lot of TMJ people over the years. So that's why I'm talking to Suzanne, the branch manager here at the bank. And I know that she said ortho 3 times. 3 times. And they can't get the teeth and the jaw in the right position. I don't know what it's going to take. Hers is pretty complicated. But occlusion is important. Big cases or little cases. So this is a young man in his 30s, comes into my office for some gingival grafting. Pretty simple, straightforward stuff. And I notice in his mouth, oh, that's too bad, a big old ugly looking silver filling. But what's significant about it is, to me, that the lingual cusp is gone, fractured off. So now, even though he's there for grafting, I wonder, because I have this occlusal orientation, what could be going on? So I put some ribbon in his mouth, and I'm not surprised. I mean, this is what I was looking for, that he had inner incline contact of the lingual cusps. So I can explain to him and say, look, I think there's a chance that these cusps could also fracture off like this one did. And potentially, they would be more difficult to repair. You could lose his tooth if you had a bad fracture. So if you will allow me to, I will, at no charge, on a complimentary basis, I will sand off these inner aspects to relieve the pressure on these teeth. Nobody has ever said no to that offer. And when they say thank you, what I say to them, and you can do the same thing, What I say to them is, my pleasure, go back to your dentist who referred you to me and let them know we took good care of you. You can do the same thing with your patients. Go back and tell your friends and relatives that we took good care of you here. And maybe they'll make referrals. So is this making sense? Let me show you a video about how important it is to listen to the directions that people give you. And we can relate that to the occlusion that we're talking about. So here we go. Listen up.
What do you have, folks?
A large pepperoni pizza.
And a Pepsi, please.
A Pepsi. Sure thing, Curly. Here you go, cupcake.
Thank you.
Hey, come here. I want you to listen very carefully to what I'm going to tell you. We both know I ordered a Pepsi Cola. And now you've insulted me and my entire family by offering me this, whatever this. For being a civilized person, I'd like to give you a chance to make amends. Capiche? Yeah. Here you go.
Thank you.
Grazie. So you see how important it is to listen to my directions, right? So that's my passion, because of my experience. I feel occlusion is such a cornerstone. And I'd saved so many teeth over the years that others had condemned because I understood how to equilibrate them and get them to tighten up. So many. So with that, let me see if I got any questions. No questions. So you're worrying me, group. You worry me because, like I said, I never know if I'm just confusing you into complete oblivion. But there'll be time for questions, because this time is going to accumulate, and we're going to be, oh, I get it. You don't want to ask questions because that'll take up more time. So we don't have questions, we'll get done earlier. That's the idea, right? Okay. Be stubborn. I really am here to help. If you have questions, you want to raise your hand. We got plenty of time to catch up, and no questions. So let's see. So what are we going to do? We'll go on. This is what we'll do. We'll go on. Okay, so we've talked about plaque control. I made arguments for it and against it. And trauma from occlusion, kind of a key parameter to me. So then there's the concept. Now we're talking about diagnosing and maintaining and managing and prognosticating for saving teeth. So I read you the excerpts from the implant editorial from a few years ago. So what about other options for saving teeth versus taking them out to do implants? So here's an example from Danny Melker, who's a periodontist down in Florida, who kind of prides himself on having never done an implant. Now, he makes it clear that if somebody really, really needs implants, he'll refer them out, but he doesn't do them. Instead, he applies very generously the principles of crown lengthening, or like I like to call it gum shortening, to save teeth like these. Now, I can understand, I've seen patients with teeth like this that have, say, lost an adjacent tooth. And the reason they lost it was because crowns wouldn't stay on the teeth. And the dentist said, I don't know, it's a bad tooth, let's just take it out. But then they still have this adjacent and they continue to have problems. And it's such a shame, because something as basic as crown lengthening, which is also one of my favorite topics that I teach. We teach hands-on work. Well, we used to teach hands-on workshops. One of these days we may do it again, on how you can learn to save these teeth. And you can see Danny's result after shortening the gum around these teeth, having so much more tooth structure available now that you can have crowns made that A, have their margins on sound, healthy tooth structure, and B, there's enough tooth structure to have some parallelism in your preps to have retention. So I understand that somebody might look at this tooth and say it's flat, there's no retention, we can put in an implant. I can understand that, but those people are wrong. Now, as far as saving teeth, they're wrong. Also, there's another aspect of dentistry that's been fascinating to me recently, because here's from that same journal that my article was just published, Decisions in Dentistry. So this was 3 years ago. I love this article. I'm pretty sure that the articles on their website is available for free. Do yourselves a favor. I have 3 articles in there. Let's see. Crown lengthening is one. The one I showed you today is relevant. And soft tissue grafting. So those are my 3. But this one on endo is absolutely fascinating. Look it up, November 2017. I'm pretty sure it's for free. Scott Doyle teaches and is in private practice. And he shows cases that he retreated. This was someone who came to him for a second opinion after having been told to have the tooth out, to have an implant placed. And he retreated it. Now look at what he was dealing with. The fill was short in both the roots. He retreated it non-surgically, if I remember right. And look at the healing of the bone. It's fascinating, absolutely fascinating that there could be such a difference in the result with 2 different clinicians. And another one of his cases. Look at this, 1, 2, 3, 4, 6 canals. On the x-ray here, you only see 2. So I guess this is why the endodontists are so loving the microscope, because I understand it helps them to identify all these canals and look at the healing. So just like, I don't mean to be critical of our colleagues, I really don't. But I have a difference of opinion on how occlusion matters and how you can treat perio, you can manage frications, and how you can save teeth with properly done endo. So read the article, find an endodontist. If they're not doing this for you, who can? Find an endodontist. Now, look, I'm also realistic. I'm not anti-implant by any means, but you've got to look at the opportunities or the limitations. So here, I agree, this is kind of heroic. If we're going to do any crown lengthening to save this tooth, we'd be taking away bone probably down to this level. Well, I don't think any prudent clinician among us would do that. So could you do orthodontic eruption? Maybe, but it's borderline. Yeah, maybe possible. Root is just maybe long enough. So I'm not against implants, but I am cautious, and I want you to be cautious and guarded and thoughtful. So we're going to open up your thought process. It's kind of sad what's out there. This is a case, periodontists have a worldwide email forum. We can post a question, it goes to everybody that's a member in the world, or we can post a clinical case, or we can start theoretical discussions. All kinds of things have been going on for decades. That's kind of interesting. So this guy posts a case, meaning to show how smart he was. He got a lot of backlash, though. He said this was a young man in his 30s or something, kind of busy, and he said that he wanted quick treatment. He wanted something quick. Oh, it says that right there. He wanted something quick. So what do you think he did? I would say quick would be to do some crown lengthening on the lingual. This is the classic crown lengthening indication. Look at the root. Look at basically a virgin tooth. No big restorations. Do some lingual crown lengthening and put a nice restoration on there. Instead, don't know how he got off track, but see, this is what happens with today's thinking. He got off track, extracted the tooth. You can see the bone graft that he did. The implant was done later, and this took over a year to get to this point. So I don't call that quick by any means. And what's sad is not that it didn't work. It's just there's a tooth that was taken out for the purpose of titanium, kind of related to the editorial that I read to you. Our thought processes are getting tainted into titanium. Look at this one. This is even more crazy. This was sent to me by a colleague who trained, about when I did. We went to dental school together, so that's a long time ago. And he's been volunteering a half a day at the school for probably close to 50 years now. Oh my God, I can't even imagine how many years it's been. And he sent this case out to a bunch of us saying, I think that my days at the school are numbered. He says, I don't know that I can handle this anymore. This was treatment planned by somebody else in the perio department for a dental student. I feel, I didn't see the case, but he feels also that this tooth is like a no-brainer for crown lengthening. It's got plenty of roots, good crown attached, take away some bone, expose a couple, 3 millimeters, just like the look, there's more tooth here, I just realized this, than the case I showed you from Danny Melker in Florida. There's more tooth. This could have been a no-brainer crown lengthening and a 3-unit bridge. Instead, the treatment plan, extract 2 implants. My friend and my colleague went nuts. He's still teaching. I just talked to him a couple of 3 weeks ago, but he's losing his enthusiasm because he feels like the profession's changed so much. So I'm a little concerned, as he is, about the future of dentistry. I'm standing on my soapbox. I don't mean this to be negative, but I'm standing on my soapbox lecturing to you. You're just innocent bystanders here, being kind of hearing my wrath. But I want to impress upon you that we can save more teeth today than is being saved. It really worries me. So that's my lesson from these couple of cases. Please understand that I believe that we can save a lot more teeth. And also understand I'm not anti-implant. Jocelyn Fine's a wonderful lady up in Montreal. She teaches at the school, and she and one of her colleagues wrote this book that she would like to see become the standard of care for a dental. Well, it even says that. Oh, there you go. So I guess it was in the back of my mind. That's the title of her book, The Standard of Care for Edentulous Patients. And I agree with her. I have patients that have said, I remember one guy, we did this exact treatment, 2 implants, a lower denture, and he had way more bone on the ridge than this patient. And he said it changed his life. 2 implants, over denture, changed his life. So Jocelyn campaigns for this and lectures. Actually, she's lectured around the world. That's one of the benefits of being a professor. So I think you're starting to see my thought process is a little different. I say have a vision. Have a vision what's possible. Have a vision to save teeth versus extracting teeth. What happens when you walk into a coffee shop? You're presented with all these choices, and I don't drink coffee. I hardly ever go into a coffee shop. But when I do, I study the menu. I don't know what to order. But I guarantee you, my wife goes, she says, people walk in, the barista sees them coming and gets their coffee ready for them. They know what they want. And the barista has it ready for them. So have an idea of what you want. Know what's possible. Now you've seen what's possible. You can't now deny that these frications won't last for 20 years because I showed you that they can. And it's not the only case that I have like that, but I can only show so many. So have a vision. We can save more teeth than maybe we have been. So I want to comment on that while we're here and talk about the thought process of creating this foundation for our clinical decision making. Before we get into that, still no questions, you folks? Good. I hope it's clear and not befuddling you. So let's talk about core values. So what I want to say about core values is that many years ago, when I first started traveling to teach the workshops that I do, I went to the Holiday Inn at the Baltimore airport. Now, bear with me. I know you're going, why is he telling us these stories? But I actually, there's a moral at the end of the story. So I went to the Baltimore airport Holiday Inn, and I got there in the evening. I This was years ago, 15 years ago when I started to do the workshops. Now, when I go to the East Coast, I go earlier in the day, or sometimes certain circumstances, I go a day earlier because I don't like getting there at night. And then when there's a 3-hour time difference, as there was when I lived in Phoenix, that when my alarm goes off at 6 in the morning, my watch tells me it's 3 a.m. in Phoenix. It'd be 4 a.m. here in Denver, but it's still too early to be getting up and then teach for 2 8-hour days in a row. That's like crazy. So I got there in the evening. I was annoyed with myself when I got there, and I was even more annoyed when I walked in and there was a lineup of people at the front desk, nobody behind the desk to help. I asked the person in front of me, what's going on? Is there anybody? Yeah, there's a guy, one guy, he went to get something in the back room. Great. I wait my turn. What are you going to do, right? Wait my turn. I get my room key. I go up to my room. It's interesting. I walk into the room, and there's a table and a lamp. But, you know, all these hotels are the same. There should be a chair here. There's no chair. So what's going on with this place? So I call downstairs. I say, am I supposed to have a chair? And they say, no, you're not supposed to have a chair. So, okay, good. I was just wondering, go to sleep. Next day, I get up and I go to teach the course. Now, at that particular course, lunch was not being served, but that was the case often. So I know my schedule, and I typically go to the room. I typically go to the phone and order lunch at the break so that it'll be delivered. I know when I'm going to be back in the room. That day, when you know it, I forgot. So I get back to the room, not to worry, because right there on the table, there's that little booklet. And in the booklet, there's room service menus, right? Wrong, no menus, empty. But I noticed right next door, the next room was the cleaning housekeeping lady. So I knock on the door. I said, hey, can I borrow the book off the table? I need to look at the menu. She said, yeah, of course, come in and take it. And in that room, I did. There was a table, there was a lamp, and next to that was a chair, just so you know, in the next door room. So I ordered lunch, put my feet up on the table. And when I ordered lunch, I talked to Ron, the same guy that had checked me in the day before. I said, you know, what's going on here? What's going on with this place? You know, no chair, no room service menus. He said, I'm sorry. You just sit back, relax. Lunch is on me. So I'm sitting there waiting for lunch, and on my desk was this stop sign. It says, stop. If you cannot recommend this hotel 100%, please call 1234. So I did. And I kept the stop sign because I knew there would be a story. But this is a true story. It's not like I make this up. 4 minutes later, there's a knock on my door. I said, that is quick room service, right? But no, it wasn't room service yet. Instead, they were bringing me a chair. A chair. Great. Now, why would I tell you the story? There is a method to my madness. You see, the Holiday Inns have been in business for a long time, and they're all over the world. All over the world. And they have a certain standard of core values that works for them and works for their customers. They even have a frequent stay program where you stay in these places, you get more points for more stays at more Holiday Inns. But that wasn't my style, and I asked the company that I was teaching for then if they would please not use Holiday Inns anymore, and they agreed. I never been back to one since. But their core values works for them, and they're still in business all over the place. I remember one time telling the story and looking out the window of the lecture room, and there was a Holiday Inn across the street. So yeah, they're still in business, but their core values works for them. I'm not telling you what your core values should be, but this was mine. That wasn't good for me. I have my standards of occlusion and plaque control and all this crazy stuff that makes me a crazy periodontist. I can't tell you what yours should be, but you can decide for yourself. Core values matter. Now, I was teaching in Texas at the dental school in Houston. And at one of the breaks, I sat down out in the lobby, beautiful in this school, and picked up the Texas Dental Association Journal. And flipping through it, I found this ad for only $79 a unit crowns. And they show this attractive lady with beautiful teeth. But take a closer look at the ad, and they're showing this as a before and after for the laboratory work that they're trying to sell to someone. which is really interesting to me because, well, her teeth are properly proportioned and very nice. I guarantee you they're not made in the laboratory. Yet this lab is promoting this. Their core values is such that they don't even know what teeth are supposed to look like. Funny, isn't it? Everybody's core value is different. So all I'm trying to say as far as this thought process is that I have wanted you to start to see things a little differently. Plaque control from a different perspective, trauma from occlusion, fence posts, different perspective. Night guards, maintaining molars. These are things you probably had no idea that we were going to touch on today. And I hope that having the workbook with the pictures in it, these same things will give you an opportunity to move forward and think and see and practice differently. Let me give you a couple more examples. Jane comes in. She has a story, and so many people have the same story, so many people. That's why the red flag is there. So many people have this story that I say it's a red flag story. She says, ever since I had this crown made, my gums hurt. Can you, doctor, make me a better crown? Fair enough. And I know you're going to look at this and say, well, yeah, of course I can make you a better crown. Look at all that irritation. The x-ray gives you no hope. Would you, oh, great, I see a question. I will get to it. No question something could be done and should be done. Is it just a scalene root plane case? No, I don't think so. This in a way is like Joanne earlier where she had a biologic width violation. Those crowns on the upper molar first, second bite were too close to the bone, impinging on the gum. Similar here. What I would like you to say, and I would like you to think about going forward, is to let Jane know, yes, I believe we can do something. I don't know what it's going to be at this moment, but we can do something. I will let you know once I get this crown off what we need to do, because there's a chance you might need a gum surgery, a crown lengthening. There's a chance you might need it. You can't tell from the x-ray. I want you just to have intuition to think differently. Because if you wait till you get the crown off and you say, oh, Jane, I see the problem. I didn't realize there was a missing tooth here. This tooth is tipped over. It's kind of fallen into the tissue. I can't make you a better crown either unless we do a crown lengthening. Well, Jane would have every right to be ticked off. So I want you to tell her that before you take the crown off. And this is something, by the way, speaking of dental school, that I learned in school. Inform before you perform. Because once you get the crown off, it's too late to make a good first impression. No, you've lost it. But here's what happens. If you tell Jane that she might need a crown lengthening and you take off the crown and didn't need it, she's happy. Well, gee, thank you for telling me. I appreciate your concern. I'm glad I didn't need it. And if she needs it, then she says, oh, well, I was hoping I wouldn't need it, but thanks for warning me ahead of time. You see, you win either way. In other words, you never, ever, ever can lose by saying you might need a procedure. I'll let you know when I get the crown off. So think differently. At this point now, it's a straightforward crown, I think. Look at how we can expose all the additional tooth and put a crown in there that from day one is comfortable and solves your problem. Think differently. Making you crazy yet? The x-ray gives you no hope, but clinically you can see an obvious need. So I'm showing you some cases to get you thinking. Bob's molars that have lasted for 20 years with frication involvements. The dental school case that they recommended extraction of a perfectly usable tooth. It's really a shame to see. So Bob's frication, this is a girl who was 14 years old, had a severe fracture of a lingual cuspid. I mean, we debated this. The dentist and I debated, along with the mother, we could take this tooth out, but 14 years old, that doesn't make much sense. Or we can do a compromised crown lengthening and a compromised crown. We can't make it perfect. But I'll bet if we do that and we improve the tissue, we put a crown in there, it's going to last for a really long time. What would be so bad if we had the finish line up here on the fractured root somewhere? Nobody says we have to get down here closer. So we saved this tooth, even then, years and years and years ago. And then Danny Melker's case, with basically no retentiveness there. Making sense? Starting to see things differently? That's my hope. That's my intention. All right, so let me take a look at that question. Okay, question. James. Hey, James. Patient's personal plaque control is a major factor in my decision, his decision, he's writing this, to recommend implant versus crown lengthening in crown. That's interesting. If they have a history of recurrent decay over a 2 to 10 year period at a certain point, I'm more inclined to go with implants. While they won't decay, it's a good choice. I will offer both treatment options, but explain my reasons for my preference. Your comments, please. Well, first of all, I love the fact that you explain both options. Because like in the case of that dental school one, there was no option. They did take that molar out and do 2 implants. So I love that fact. Patients should be participating in the decision making. I don't mean to be critical. I think you're being a little harsh on these people because what comes to my mind, Jim, is that if you take out this tooth but you keep others, they still have the risk of decay on the other teeth. So you asked me for my comments. So that's the first thing that comes to my mind. Second thing that comes to mind is if a particular tooth or teeth are really compromised by the decay, I think that's a perfectly rational decision. So I'm not saying every tooth should be retained. They may be compromised to the point that an implant would make more sense. But your rationale, if you're replacing a couple of teeth, still means that they have issues with remaining teeth. But I have really, really interesting news for you. It seems like people struggle with their plaque control because what we ask them to do is too difficult. I mean, like that tufted end brush was too difficult for me to use, for crying out loud. So sometimes they just can't manage it. Well, the good news is I told you about the Clorox. The person that I learned all this from is a periodontist microbiologist at USC. Jorgen Slotz is his name. He's a wonderful guy. And his graduate students have recently been doing studies on using dilute and even more dilute bleach, Clorox bleach, in 2 different ways, and publishing that the use of rinsing with this dilute bleach at different intervals depending on the concentrations, which we'll talk about later. I said it again. Absolutely controls periodontal disease, even if they don't do scaling and root planing, even if they don't do toothbrushing. So it's also useful to prevent decay. So if you have somebody like this, Jim, you will probably find that people will be able to be compliant with the rinsing because we're only asking to do it twice a week. There's another concentration that's used where people have to rinse twice a day. Jorgen agrees. He recommends it twice a week. I think asking people to take a bottle of bleach, even if you keep it in a little bottle, and mix it up fresh twice a day is going to risk bad compliance. So I'm with you, Jim, as far as having too much decay history, that you may be making a good choice. But I'm also thinking that you might find that this afternoon topic will appeal to you for helping some people to control their decay. Any more questions? Oh, wait, it says there's one more question. Oh, nope, it's the same one. Okay, so I did the questions, and I'm wondering if you're starting to think differently or not. All right, so let's see where we are. Okay, so let's take a look at the next topic now that you're starting to think differently. All right, so we've gone through these: plaque control for and against trauma, my soapbox lecturing you on saving more teeth. Now let's look at the challenges and opportunities with maintenance care. Already talked about the Armitage Robertson's article a couple of times. I told you about the BU versus Tufts Dental School arguments, debates. But we've learned that most any treatment works in the face of good maintenance care and good plaque control. So with that in mind, let's talk about it a little bit. So I want to propose the fact that my experience is that maintenance care for a perio patient, hygienists, you may or may not agree with me here, is different than maintenance care for a non-perio patient. The biggest difference that hygienists talk to me about when they come to work in my office, when they've worked at other times in general restorative offices, is that they often aren't given enough time in those other offices, and that in the perio office, we give more time. Matter of fact, I had one hygienist who's a doll, but she struggled even with a full hour, so she was more comfortable with an hour and 15 minutes or something like that for a perio maintenance visit. So we're going to charge differently, and we're going to do differently. Like, for instance, I want you to think about the fact that, because I've had patients complain about this, that they're used to, in a general office, of getting pretty even-handed scaling and root planing, or just, scaling whatever is necessary throughout their mouth. They come to our office, and we might spend, we'll just say for sake of argument, 50% longer time scaling just the molars, for instance. And then we go quickly over the rest of the mouth, and they say, she wasn't very thorough. She just spent time, she didn't spend much time on these teeth. And people don't understand the difference, and that's why, as a hygienist in a perio practice, what we would talk about is why we're doing that there is a difference. Also, we might spend more time doing plaque control reviews, and we're going to talk about that this afternoon. I won't tell you yet what we're going to do, but we're going to talk about that this afternoon and what we have to help people understand it better. So it is different. We focus more on certain issues, not spending equal amount of time. And like it says on the slide, it takes some education to get people on board with that. Also, we're going to spend some time going subgingivally. And again, I apologize. We're going to keep saying things this afternoon, but I will tell you that I've always, even before this pandemic stuff, always believed in rinsing with, iodine, betadine before a visit, surgery visit or maintenance visit. So always wanted to do irrigation and rinsing with the iodine. And then we're going to work subgingivally to get rid of the toxins, the bacteria, subgingivally with irrigating. So hygienists that come over to the dark side learn to have a little different approach. But I have some tools we're going to talk about this afternoon that really are educational. So the difference between a, quote, prophy and a perio maintenance are clear. And One is actually like the perio maintenance can actually be more therapeutic. That's why we do it more often, sometimes 2 to 3 month intervals, depending on people's skill level, how they're maintaining their own mouths. And as I said, we might spend a lot of time in certain areas versus the whole mouth equally. Well, Diane Watterson, who maybe some of you have taken classes with her because I haven't followed her schedule, but I know she does some programs also for Concord. And although I haven't met her, we've talked and emailed, and I've admired her publications. She just does a beautiful job. So this is from last year, an e-letter that was part of the RDH magazine community, where she wrote an article comparing the, quote, prophylaxis to a, quote, periodontal maintenance visit. So you can see for the most part, they share a lot of commonality. All these items have to be done at either a prophylaxis or perio maintenance. But the perio maintenance, the column on the right-hand side, is different when we get into other factors. So the perio maintenance has all these other things that are not part of a routine prophylaxis. Standard of care says we have to check probe scores. We can maintain 5s, as I said to you, routinely. We might use the ultrasonics. We might do antimicrobial application like the iodine. We might use different instrumentation if we have deeper areas to maintain, on and on. So there's different aspects to a periodontal maintenance that can't be done, and I don't expect my hygienist to do it in a limited time frame as they might have been used to doing. But if people will comply, and if they will come in for these visits, we can help them, as Tom Wilson showed over 5 years, to not lose any teeth. So 1/3 of his patients that paid him for treatment and went through therapy, only 1/3 stayed compliant. Kind of shocking to me. So if people will do that, they didn't lose any teeth. And we can even maintain these questionable molars for decades with compliant people. So there's been quite a bit in the literature because I've looked around, and it's interesting with the internet how you can find things and go on the perio site. This is a perio journal, and search for these things. So here's colleagues here and in Japan that 14 years ago published in the perio journal how things turned out when people were compliant. And if they would be compliant, would you as a clinician be able to make a decision about what's going to happen down the road for them? So this was a 15-year study or longer, and a complier was considered compliant if they missed less than 30% of their appointments. So they could miss some. They didn't have to be perfect. Actually, I'd have to go back and read the Tom Wilson study. I'm not sure if his had to absolutely be compliant every 3 or 4 months or not. I can't remember. But in this case, you were still considered a complier even if you missed some visits. And the compliers had better periodontal parameter scores afterwards. So the conclusion was that if people would comply, they would have a chance of success. But then they pointed out an interesting confounding factor, different than the Tom Wilson study, that these compliers actually lost more teeth than the non-compliers. And I think what they were seeing is that when people would come into the dentist and a tooth looked questionable, like Bob's molars with through and through frications, these well-meaning dentists would extract those teeth. Kind of ironic, isn't it? So the Wilson study lost no teeth, but the BU Japan study, they lost teeth. So that's my point about maintaining more teeth, is that Preston Miller's study showed us that if people comply, that they'll do well. This study kind of shows the same thing. The Wilson study, the Scandinavian studies all show that if people comply, they save teeth. So don't fall into the fact that if a tooth is questionable, you have to remove it. Titanium is not the answer. That's all I'm trying to say with that study. So this is what we've been trying to look at so far, is plaque control, for and against, occlusion, implants, and maintenance challenges. All these things happen. So now it is 11:20. And we're going to go in a different direction now. Hygienists, don't get lost here. Don't get discouraged. I know this will feel more doctorish, but this is kind of a foundational principle as well, what we're going to talk about next. I know we talk about soft tissue management, and hygienists probably talk about a lot of soft tissue management, but I want to talk to you a little bit about bone management. It's a different process, and it actually is the key to a lot of things that we do. When I've showed you cases, I show you x-rays. And this afternoon, I'm going to show you lots of cases, and I'm going to show you x-rays on every one of them, because the bone is what really makes a difference. So keep this little jingle in mind when we're talking about soft tissue management. So there you have it. The tissue is the issue, but the bone sets the tone. I think it's an important principle, and I don't mean to be over the head of hygienists, because I think that you can, if by understanding this, you can help patients to realize that they can save a lot of teeth, they can manage, maintain well, and you can guide the treatment, because if there's enough bone, we can do a lot of things. So let's look at this from a new perspective. We're going to talk about eliminating pockets, and we want to achieve very maintainable tissue, right? So in order to get to that goal of ideal, manageable, maintainable tissue, we have to understand the role of the bone in being able to accomplish that end result. And bone is what makes the results more predictable. Now, I'm not even for a moment saying that bone surgery or bone management will cure periodontal. No, of course, we still need the compliance, but we're going to get into that again in the second section this afternoon. From a bone standpoint, it's been published and explained to us in the dental literature that in ideal bone anatomy, the bone crest will follow the CEJs. So that means up and over interproximally. The CEJ goes up and over, the bone goes up and over, not cratered. The bone has to have this let me get this word right, convex pattern as the bone goes up and over interproximally. See, convex bone. So here's bone that has some slight pocketing, some slight concavities as a result of this thick bone. This is most of the bone surgery we do, and with the crown lengthening surgery that we do and that I teach, it's often because of this thick buccal or lingual bone, really common. There was a study done, I think I'll probably mention it this afternoon, but periodontists found that 79% of people, when they flapped their maxilla, had bone on the lingual of the molars, thick bone, you know. So that's what leads to the tendency for pocketing, because the bone is thick and the pockets develop more easily. So if we want to have a healthy environment, we have to have this kind of concavity interproximally, not any reversal or negative architecture, because the soft tissue still wants to make a papilla here. So if the bone is lower and the papilla is higher, you just have a pocket. So that's why the bone should be the same shape as the way the gum tries to grow, which is to make a papilla. So we make the bone follow that. And here's an example. So here's a relatively healthy mouth. I mean, it's not like Blake or Samuel from earlier. I mean, it's pretty clean mouth, but there's missing tissue everywhere. Why? Why is the tissue gone? Because the bone is gone. So if we're going to treat this, we want the bone up to support the tissue. So here's what we find when we flap this open. Clean, early case. These are the kind of cases you can treat surgically. Early cases, not heroic cases. But there's cratering in the bone. And so what happens? The soft tissue collapses. In order to make this manageable, we have to create positive architecture with the inner proximal more coronal than the radicular. Just like you see here in a skull specimen with no bone loss at all. The inner proximal is more coronal than the radicular. And here's what it looks like on the lingual. Cratering interproximally, probably worse than the buccal view. And when we alter the bone, we're taking away this bone and scalloping it and taking away this bone so that we have this scalloped shape of the bone, because the reason for this is that the gum is trying to do the same thing and make papillae. If the bone goes the other way, there's your pocket. So doctors, if you're wondering, I don't know if you do or don't do any perio surgery, but if you're thinking that you want to or do, these are the kind of cases to treat. Early bone loss. You don't just put these people in a maintenance program and then let them come back every 4, 5, 6 months, because the craters will create pockets which eventually will break down. Much easier and more predictable to treat these early than advanced. Now here's an example. Way too late. What you're seeing there with the arrow, it shows the Furca probe, the curved probe, coming from the, well, I actually don't know, I don't remember, from the lingual, the distal furcation, or maybe the buccal. But you see it goes through and it comes out here on the mesial furcation. This amount of bone loss, this amount of furcation involvement cannot be treated like the previous one. So this other case, easy, predictable, routine bone surgery, nothing heroic. These are the cases that are treatable, not these. So this is the case we looked at early this morning. Tissue wants to make papillae. So very thick tissue. Look at here, we're probing a 3 out on the buccal. As we step the probe into interproximally, it drops into somewhere around 5. So can you picture in your mind that there was a crater? Can you imagine that the first probe score, this one here, was out here on the buccal, and as we step interproximally, look, we fall into this crater. Here's a more exaggerated view of a crater. Can you visualize that in this mouth? It's a very minor crater, but these are the craters that we want to treat. And I'll give you a reason, a rationale for why we want this more definitive sometimes. So here's what it looked like before. After modifying the bone, we can eliminate the pockets clearly and predictably. So A, does that make sense? And B, if it does make sense, can you think of a couple reasons, because I'm going to show you, a couple of reasons why pocket elimination might matter, or being able to control the disease at least might matter? Well, the first one is that people might be variable with their compliance. So this result at the bottom is very maintainable. Here's a result with Sharon that was being, quote, maintained, that wasn't definitive. And Sharon was doing well as long as she came in regularly to the office. But then she moved away and for 6 years had no care. And that 6 years of no care undid her periodontal stability. So she hadn't gotten on board with the compliance, and she lost the, well, she moved back. And then we found, this is what had happened over the years. So if people are on, like Jim mentioned, people have had a lot of decay. Maybe that's a reason not to try to maintain certain teeth, and I can't really argue with that. But if you're going to be doing restorative care, I would propose that you want to have the most predictable result possible. So that if you're going to do restorative care, I'm going to back up. Wouldn't you rather have that tissue, the post-op, than this? Because this is hard to maintain. It's hard for you hygienists to maintain. It's less predictable. And if this is a restorative case, you would want to do ideal bone contouring and ideal tissue maintenance. And the reason for that is this. Soft tissues have a mind of their own. Watch my hands here. They want to make a papilla. They want to grow up. So if the bone is going down and the gum is growing up, what's this? This is called a pocket. The gum tissue cannot adapt to this bony architecture. So if you're going to be doing a restorative case here, then it'd be nice to eliminate these pockets to have that predictability if people become less compliant. So maintenance care can be achieved better with predictable bone and tissue. Now, here's another example of managing the bone. Now, this is a crown lengthening situation with a broken tooth. But what I want you to see is that there's bone here that's been shortened. See, we've reduced it on the mesial, not we, but the authors. And they've reduced the bone here on the distal of the bicuspid. Because if they left the bone up here higher, then the drop off from that bone level down to the adjusted new bone level on the broken tooth is too steep for the soft tissue to follow. And that's why the bone is modified on the two adjacent teeth. It's only done for one reason, to accommodate the gum, because the gum has a mind of its own. So here's a clinical example to show you that. Fractured lingual cusp. Enough tooth there to do crown lengthening, but in the process, we have to flatten out the bone. If we left the bone up high on the distal of the bi and the mesial of the molar, then that drop off to the adjacent root would be too steep. The gum won't follow that. It's exactly like this picture. The gum won't follow it. So we have to lower the bone on all three teeth. And look at how that changes things for us. Here's the pre-op. Notice the size of these two teeth compared to the post-op after surgery. Yes, we've exposed by means of crown lengthening enough tooth structure there to have adequate retention for your restoration. But in the process, we've also made the adjacent teeth longer. But no harm was done because, in fact, like I said, these teeth have too much bone to begin with, and that's why these crowns were smaller than average to start with. Afterwards, now they just look normal, right? So bone is the determining factor here. Does that make some sense? I hope. Let me see if there are any questions. Negative. Okay. So bone is the key. Now, look, I told you, well, I don't want you to read it yet. I told you that I was going to get you to think differently. I mean, you could argue that maybe I'm wrong. Maybe I'm too anal. Maybe I'm crazy periodontist. You could make all these arguments. That's fair. I mean, we're always going to debate that. You know, we always say if you want to know what kind of bone graft product to use, you ask 4 periodontists, you're going to get 6 different answers. So we're all a little anal. But look at what these people wrote in their textbook 2 decades ago. The true measures of success, they wrote, are the elimination of the defect, pockets they're talking about, with little or no removal of bone. What do you think? I'm here telling you bone sets the tone. I'm here showing you that if you want to do proper maintenance, you got to do proper bone surgery. But it just dawned on me, I realized that we are doing a small amount of bone surgery if we do these cases early enough. Don't wait for the heroic ones. They can't be managed that way anyway. So I say that comment makes no sense to me. Manage the bone properly and you'll have better results. So this is my conclusion. You treat early bone loss. You don't wait till it gets blown out. It's too late. Initial therapy we think of as scaling and root planing. That's not the answer. That's not definitive. If you're doing restoration cases especially, you want the tissue to be well adapted to eliminate pockets and make for predictable maintenance opportunities. All right, Karen is chiming in with a question about bone regeneration and my thoughts about laser therapy. All right, this is an interesting question, which, by the way, you folks are going to shoot me. Well, you can't because we're not together. But we're going to talk about that this afternoon. I swear we are. We really are. But to answer it now, let me just tell you that, yes, I believe that laser therapy can result in bone regeneration. But hold on, before you run out and buy a laser, or before, those of you that have a laser say, oh, man, this is the best. Karen, let me also point out to you the fact that I showed you earlier that we could grow bone in the properly shaped defects if you put in plaster of Paris. So is it the plaster of Paris or the laser therapy that grows the bone? Or is it the shape of the defect? See, I would argue a lot of it is the defect. At the same time, I will compare this afternoon laser therapy to the antimicrobial treatment we're going to do this afternoon. They both will grow bone. So again, it's not the laser. It's the application of certain principles of killing bacteria to let the body heal. So it's not just the laser. Sorry, I hope I answered your question in a way that's satisfactory. Now, what about another form of surgery called gingivectomy? I don't see it as having a role anywhere because we're talking here about bone and having craters and thick bone. So if you cut off the soft tissue, i.e. gingivectomy, and you don't modify the bone underneath, because remember, bone sets the tone. If you don't modify the bone, then the gum just grows back where you did the gingivectomy and the pocket's there again. So gingivectomy is not the answer. Now, there's also another theory on bone management called rebound. Let me tell you about that. Those who say that rebound is valid claim that putting the flap, you open up the tissue, you put the flap back at the bone crest, like if you did a gingivectomy, right? You cut the gum off to the bone crest. That will allow for a regrowth of tissue between 2 and 3 millimeters. Is that true? Or is that regrowth the normal reestablishment of biologic width? It's not some phenomenon called rebound. And if it is the normal establishment of biologic width, for those of you who already know the dimensions of the biologic width, well, then you know it's 3 millimeters, not 2 to 3. That's a difference of 50%. And if I'm doing a restoration, I need to know where my tissue is going to end up. I can't count on some unknown of 2 to 3 millimeters. I have to understand biologic width and know the tissue is going to grow back. So here's an example. You cut the gum off, you put it back at the bone, it's going to return, right? To the dimension of 3 millimeters biologic width. So this has also been studied. This is in the literature. Here's one example of it. There are others. This was a crown lengthening study done by Days and colleagues, where they did crown lengthening and found that there was more gum regrowth in some cases than others, some more gum rebounding than others. So that kind of validates the definition of 2 to 3 millimeter regrowth. But the problem is the whole thing is faulty, the whole thing. So they looked at it and they analyzed why in some cases did we get more gum to grow back than others. And they figured it out. And their conclusion was that it had to do with where they put the flap. So you see what they said was, well, we did some bone surgery and we exposed some tooth for crown lengthening, but we didn't have enough. So we realized in some cases, we could put the gum down lower, closer to the bone to expose more of that tooth. And then they realized that it was those positionings of the gum flap that led to the rebound because they didn't change the bone. So there wasn't enough bone reduction, and when the gum grew back, it grew back to the whole 3 millimeters. Watch. So here it is. I was trained that way, by the way. I was trained to suture the gum down here at the level of the bone. The problem with that, this was only 3 months later. You see here the CEJ all along here? Now the gum had grown back in 3 months and it got closer to the CEJ. So what is this? Is this rebound? Is this some unknown regrowth of gum? No, it's the normal regrowth of the biologic width. The bone matters. See, we're still talking about bone, why it matters. Bone sets the tone. So in this case, Mark, very tempting. To get a better impression for your crowns, look at this. The gum is actually higher than the occlusal of the prep. And so is the interproximal. Wouldn't it be tempting to take your electrosurge or your laser and just zap off all this tissue and so you could get a better impression? And I'll bet people do that. I'll bet people do that all the time. Well, the problem is gingivectomy, whether it's with a blade or a laser or an electrosurge, is not the answer. Getting rid of this bone is the answer because the bone is going, the gum is going to grow back. If the gum wanted to grow back to here and you cut it off, why would it grow back anywhere different? It's programmed to make a papilla, like I showed you earlier. If you cut that off, it just grows back. The only way to control where the gum goes is to modify the bone. So bone, I know hygienists are probably going crazy right now. Oh, he's not talking to us. Bone sets the tone. So we thin the bone, and that's what gets the gum to lie in here. Hygienists, you have to admit, wouldn't you rather maintain a situation like this with supragingival crowns and minimal sulcus depth than to try to do something like this? Take a good look at that picture. So bone is the planet around which all this revolves, which brings us to the understanding of biologic width, which I mentioned briefly earlier. So my question to you, all of you, is this biologic width something that's really useful to you as clinicians, hygienists as well as doctors, or is it purely something of academic interest that is less important clinically? I'll let you decide. I kind of have my own feelings. You see, because biologic width is so easily misunderstood. When I first saw this diagram, I didn't see the fallacy in it. Someone had to point it out to me. If you go online and look up biologic width, you will see this identical diagram and dozens or hundreds of similar ones. And if they're very similar to this, they're probably wrong as well. Now, they will all have one thing in common. Well, I guess you could have three things. So all have this in common. They all will show these same measurements because these measurements came out of a study published in the 1960s by colleagues in Chicago by the names of Garagiola, Wentz, and Orban. Orban is the son of the Dr. Orban that some of our instruments are named after. And they did a study of cadaver specimens in the 1960s where they measured the dimensions of gingiva. And these are the measurements that were in their study. 1.07 millimeters was the dimension of connective tissue. 0.97 epithelial attachment, and about 0.7 for sulcus. But this diagram's all wrong. It's all wrong. You see, at the end of the article, there was a little table, this big, just a tiny little table. And the table said, so in looking at the different stages of recession in our cadaver specimens, we came up with 4. A young adult, totally healthy mouth, very young adult, healthy adult, older, different levels of recession in groups 1 through 4. And they said, on average, all the 4 groups, these were the numbers that we came up with on average. So these numbers didn't apply to any one group, but an average. Also, the other mistake in this diagram is the epithelial attachment here is on the enamel. That's only true in group 1 of their study, young adult, very young adult teenager kind of population. So after analyzing these, many people today have come up with the attitude that really these dimensions are all 1 millimeter dimensions. Connective tissue, epithelial attachment, sulcus. And this is a diagram of stage 2 from the Gargiulo study, healthy adult. Notice that the epithelial attachment here is also on the root. And notice the dimension goes from the tip of the osseous crest to the tip of the gingival margin, roughly 3 millimeters, just a hair over 3 millimeters. So that's why conventional wisdom says 1, 2, 3 for the biologic width. And that's what I said earlier when we're talking about rebound. It's not rebound to some unknown dimension. It's the normal development of the biologic width, redevelopment of the biologic width. So what's the significance? Do you care? Should you care? I think you should care. I think that hygienists, you should care because it'll help you to make a diagnosis if somebody comes in and says, my gum is red and irritated, like Jane with that upper molar and all that red irritated gum. You can determine where the margin is relative to the bone with a little anesthesia and probing up under there. So you should understand these. Doctors, when placing a crown margin, these measurements are significant because if you look here, when you probe under anesthesia, mind you, so people use the word sounding. When you sound for where the bone is, under anesthesia, you will bump into the bone up here at essentially 3 millimeters because we have three 1 millimeter dimensions. You know where the bone is now. You know where the gingiva is because you can see it. What's your guideline for placing your crown margin? Do you know where the sulcus ends? Can you feel where this sulcus ends? The answer to that question is no. You can't feel where the epithelial attachment is attaching to the tooth. You can only feel where the bone is. So therefore, we tend to believe that if we keep our margin, our crown margin, within this sulcus, no more, doctors, than a 0.5 millimeter subgingival, that we're staying safe away from this delicate soft tissue reattachment to the tooth. So we have to stay within this, no more than a 0.5 millimeter. That's why understanding biologic width is significant. You don't know where the sulcus ends, and you want the crown not to impinge on the soft tissue, so you have to stay within a 0.5 millimeter. So are these dimensions real, you might ask? Yes, they're very real. So take a look at this skull specimen from my friend's office. I was there one day, and I noticed that there was calculus on the skull. So we grabbed a probe, and we measured, and there you have it. That same 3 millimeters. The body knows the dimensions. That includes 1 millimeter of connective tissue, epithelial attachment, and 1 millimeter of sulcus down to the gingival margin, 3 millimeters. So the answer to my question before is yes. I believe biologic width is useful. Hygienist, you could use it in Jane's case, in Joanne's case, the one I showed earlier with the upper first molar, second bicuspid, where the hygienist and the doctor were telling her to floss more. that you could have diagnosed that hygienist could have too. Diagnosed it with a little anesthesia and probe, feel up under there. Here's the crown margin. Oh, let's keep probing. Oh my goodness, look, the bone is almost touching the crown margin. So there's not a room in there for the biologic width, connective tissue, epithelial attachment to form because the crown is too close to the bone. You hygienists could have made that diagnosis for Joanne, but instead they told her she wasn't flossing enough. So there you have it. There you have it. So bone sets the tone. Okay, so I have good news and I have bad news. The good news is we're cruising along time-wise. And like I said, I think you just want to do this so we get done early. The bad news is it's time for questions again. So, no questions. So somewhere along the way, you're going to have to let me know that this is making sense. Enough sense that you're okay with not asking questions now, as opposed to the fact that I've confused you and you have to ask questions because you don't have any idea what I'm talking about. All right, so we're really going to get, we're going to go through another section here, hygienist, where we're going to talk about bone and bone surgery and furcations. Again, different aspect of furcations than what we talked about earlier. And doctors, a little tiny bit of bone surgery. When I first started to do lecture, oh good, there's a question just popped up. When I first started to do these lecture classes, which I really did in combination with the workshops, the morning was all lecture, open to anybody. We, you know, at a big conference, Chicago or California, you get hundreds of people come to the lecture, and only those 25 or 30 people we could accommodate would come to the afternoon workshop. So when I first started to do that, I didn't put anything in there about how to do the bone surgery, how to use burrs, et cetera. And so people explained to me that they were coming to the lecture and not the workshop because they already were doing these things at home and they wanted to get a few surgical pearls. So this morning, there will be a few surgical pearls in case some of you are in that situation. I never know, so I don't know if I should leave it or take it out, but it's in there. All right, so let me see what we have here. Jim, where would you like crown margins? I would like and in the crown lengthening classes, which, by the way, I'm embarrassed to tell you. Next week, I wasn't sure it was next week. I think it's next week and next month also. Yeah, it is. Next week and next month, an evening webinar, 2 hours. I will be talking about crown lengthening concepts. And in that discussion and in the workshops, I definitely suggest, well, it's like Mark's case, those lower molar, a few slides back, where we didn't do, I said not to do gingivectomy, but you have to do the bone surgery. In that case, if you remember, were all subgingival margins. Those were lower molars. I mean, why not? Jane's case, that upper molar, or Joanne, the upper molar bicuspid case, where the tissues have been impinged upon and they've suffered, in Joanne's case, 5 years of being told to floss more. I'm all for supragingival margins, Jim. So thank you for asking. I mean, as restorative, and I ask this at the workshops because I'm a periodontist. What do I know? What am I supposed to know about these things? So I always ask the people when we're live at a workshop, do you agree with this? And, you know, those of you that are restorative people that put a note in the Q&A box that you agree or don't agree. I mean, I'm willing to listen. But I say on those lower molars of Mark, a few slides back, no reason to do subgingival margins. Easier, more predictable impressions and maintenance, the whole thing. So Jim, I prefer supragingival as somebody who's been around this topic for a while. All right, let's see. Is that it, Jim? Thank you, Jim. All right, so, okay. So moving on to bone surgery. You already know that bone sets the tone. Anybody else want to raise their hand and talk about these topics? It's okay. Since I don't see it, we're going to go on, and then it'll take us into lunch. Okay, so here's a bone problem. Here's a bone problem with two issues. There's inadequate crowns because there's too much gum tissue, open margins, some sensitive and decayed teeth. There's also, as you're going to see in a moment, some cratering as a result of all this extra gum tissue, kind of like the case we looked at earlier, Larry's case. Well, a different Larry, but Larry. Okay, so how are we going to manage this from a restorative standpoint? The bone sets the tone. So if you look at Barbara, she's got very thick bone on the buccal and on the lingual. Look at this torus. So if we're trying to get the gum, remember gum has a mind of its own, to lie down and make room for new crowns, how do we do it? We do it by managing the bone because the bone sets the tone. You know that now. Bone sets the tone. So let's see what we're dealing with. There's craters and there's thick bone. Look at the preps are practically touching the bone. So are these preps impinging on and violating the biologic width zone? Absolutely. So if you were not to manage the bone here, you would A, be left with craters, which would potentially get worse over time. B, you would also potentially be having biologic width violations like you saw with Joanne and Jane that could cause sore, irritated gum tissue. So there's two reasons here for doing osteosurgery and doing it properly. And you can see the difference in the way the tissue, the bone looks here, that we've made these bone profiles reflect what nature showed us on those skulls we looked at earlier, namely more coronal interproximal bone and more apical radicular bone. That's the positive architecture of scalloping. This is positive architecture like you saw in a healthy skull. And we maintain that same pattern of positive architecture with higher coronal bone when we go over the frication. Why? Because if we take this bone down and make a scallop across here like we did on a single rooted tooth, we're exposing the frication. That's the last thing we want. We want to protect the bone. Now, the other feature of taking care of this bone that we talked about earlier was avoiding rebound. I showed you the Days study, the colleagues that worked on why the gum rebounded. Well, other people have written on the same topic. Also here, evaluating supracrestal gingival tissue after crown lengthening. What these colleagues also found in India, there's some nice research coming out of India, was that they said, not me, I'm not making this up, in order to avoid gum regrowth, rebounding, you must manage bone reduction. So you see, it's all about the bone, not apical positioning of the soft tissue, which is what they did in the Days study. And then they found a problem with some rebound. It's because they didn't manage the bone correctly. So here also, literature guiding us to do the bone. Now, some of you might be saying, I don't know how much of this you cover in hygiene training, but some of you might be saying, well, this is just not true. This is just not true. That amount of bone surgery shouldn't be done. Now, I know that people believe that, and I know there's been a debate, and there's a reason for it, I think. some years ago, there was a big, I'd hardly call it a debate. It was an argument where a couple of guys were periodontists. These are periodontists on the worldwide email forum were saying bone surgery should be outlawed. Some people agreed. Some people like myself said, no, I don't agree. But the argument was never resolved because these people had long-standing beliefs that that's what was correct. So not too long after that, I ran into a periodontal colleague at the gym and I said, hey, did you see that stuff? Oh yeah, I've been following that stuff. What do you think? Oh, I agree. Bone surgery is bad. I just gave you a whole story why bone surgery was essential for eliminating pockets and especially essential in the case of doing a restoration, especially a big restoration. So where do people come to the idea that bone surgery is no good? I think I have an answer. This is an article that appeared in 1970. So you could argue, oh, that's old stuff. But, you know, this is when a lot of the periodontal concepts were formulated in the 60s through 70s. So these colleagues at Tufts were studying how effective it was to do osteoplasty to eliminate pockets. Osteoplasty just means you're reshaping things versus ostectomy, which is like a gingivectomy. Gingivectomy means you cut off the gum. Ostectomy means you cut off the bone. Osteoplasty just means you're smoothing it up a little bit. So they did it. They documented their work beautifully. I'll show you in a moment. Not this afternoon. I'm going to show you in a moment. How's that? They concluded osteoplasty gave no more benefit in eliminating pockets. See, that was the goal in the study. No more benefit than just open flap, clean it out, close it. Same result. And so they show two different sides of the same mouth. One was done with flap, one was done with flap and a little minor bone surgery. So they were right in stating that the result was the same. No difference between the bone surgery case and the flap only case. So they were right about that. But they were wrong in a big, major, significant way. That the conclusion was that their conclusion was that bone surgery was ineffective in eliminating pockets. See, because they studied only osteoplasty. And what they needed to do in order to have eliminated the pockets was do ostectomy, cutting off the bone. So let's look. Here's how they documented their work. Gorgeous impressions at the bone level. Flap, clean out impression of the bone before they started. This was immaculate documentation. Then they did the bone surgery in the form of osteoplasty, not ostectomy, and they took another impression. So they proved with these two impressions why their conclusions were bad. Their conclusion was no reason to do bone surgery because it didn't help. My conclusion is no reason to do osteoplasty, you must do ostectomy. But here's the problem. In 1970 or 2020, I cannot do ostectomy on this amount of bone loss. Can't do it. You can't take away all this bone to make positive architecture because you'd have to scallop down here too far. I would treat this tooth the same way today as I would have in 1970. Extract it. Or, I'm sorry. If you're looking for a definitive result, maybe you're doing restorations. If you're just trying to maintain it, well, you just maintain it. But if you're looking for a definitive result, you have to extract it. And then the two adjacent teeth, mesial and distal, will heal. But if you want eliminated pockets for the purpose of a definitive result, say for restorations, you can't treat that tooth. So here in Barbara's case, we easily could treat this because she had only, I don't remember what the probe showed, but I think it was a 2, maybe 3 millimeter crater at the most. So we easily could recreate positive architecture that reflects exactly what this skull specimen, which is a perfectly healthy bone pattern, reflects. This mimics this. Here, you couldn't do it, too much bone loss. But you see, some in the profession feel that bone surgery is never to be done because this proved it didn't help. But it proved it by proving themselves wrong. So in Barbara's case, we have some cratering in here, plus for the purpose of crown lengthening, we have to take care of the thickness here and the thickness here. So you can see that looking from on top, and now looking from on top. See how much bone we took off? Thinned it in. And 4 years later, we have maintainable, manageable, accessible crown margins, no pockets, easy maintenance care for the hygienist, because we followed bone principles. Positive architecture. Questions about that bone stuff? Let's see. No. So in case some of the doctors are doing the surgery, these are the kind of pointers that people in the lecture classes have told me they want to know. In the workshop, I would cover this material as well. I am a huge believer in diamonds being safer than carbides for doing bone surgery. Maybe you've done some work with carbides and you've seen it touch a tooth and skip right off the tooth. It skips if it hits the tooth wrong. So I say when you're flapped open, you want to be safer and use the diamonds because they don't skip around. Thank you. I see another question. So I had somebody at one of the workshops say, you know, I took a course with Dr. X, who I knew, and he said that we should use carbide burrs. I said in the most humble, sincere, generous way that I could, he's wrong. I tried to be nice about it, but I called him up. Now, he not only taught courses like this to dentists, but also at a dental school. I said, someone in class told me, blah, blah, blah. He said, yeah, that's true. I do tell people they should use carbides. He said, but I tell them that they could skip and they should be careful. I mean, really, they should be careful. Dental students that are teaching how to do this and people in practice that maybe have never done it, they should be careful. Doctors, if you're doing this, please use diamonds. They're much, 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 much more safe. And if you are curious, I do have a burr armamentarium that I like. You can see what it is here with 4 round burrs of different sizes. A skinny burr in case, like you see here, for at one point you may not be able to get a round burr in approximately. It doesn't happen very often, but it does. Plus 2 end cutting burrs to more safely get in between the teeth when you have provisionals like this that you take off to flatten the interproximal bone. If you're interested, send me an email and I'll send you information on where to order them and how to order them. They are surgical length burrs. If you have burrs in your office that are regular length, they'll complicate you doing the procedures. So I believe diamond burrs are way, way, way safer. So those are my little basic thoughts on bone surgery that I put in there, like I told you, because people have said in the past that I didn't include some pointers. And we'll close up before lunch by saying a little bit about frication management. So we talked about frication management from the standpoint of periodontally involved frications, and we know that they can be long-lasting with the dilute Clorox. But this is frication management from the standpoint of preparation for restorations. So you can see here in Barbara's mouth, we had the thick bone, we thin it, we scallop around all teeth, and we scallop the molar as if it were 2 single-rooted teeth, with the frication being more coronal, just like the interproximal was more coronal. So that's how we manage healthy frications if you're preparing them for, well, I said for restoration. In this case, it could be a restoration or straight pocket elimination. Either way, that's how you manage the frication. Now, if we're doing restorations and we got provisionals, we have different considerations. So here's the provisional that's taken off, and you can see that the furcation here, unlike Barbara's, has some horizontal bone loss. So the probe goes in to 3 millimeters. If you just restore that the way this tooth is prepared, you've got this horizontal tunnel, that's basically a pocket, which will continue to deteriorate. So I might do this at the time of surgery, or you might do it at the time of preparation. We would loose out the rest of the tooth above the furcation. This is called unroofing. So it'd be the same thing as taking the roof off the front porch at your house. Unroof it, and now you look up to the sky. So we're unroofing the furcation. Here's what that looks like. In the mouth, you can see it's been unroofed. The temporary has been refitted. And the new temporary looks like this, where you can see where the barreling was done and the crown is reshaped as well, compared to this where it started before the surgery. Now, Danny Melker has a case that he shared with me that illustrates it better because my pictures on this were a little lacking. But same idea. Furcation is barreled out to the sky. But here's the key thing. I showed you in the provisional that it was contoured to adapt to the furcation, but so is the final restoration. Some doctors would have their laboratory people bring me the case in the wax-up stage to be sure I approved of the way they handled the furcation, because some laboratory people, thinking they're helping us, will restore this contour to full contour. And now what they did was they built back the roof on the front porch, and you got a tunnel under it, and you have a plaque trap. So there you have it. There's another bone surgery concept. Now, I haven't asked, it's a little awkward to ask who does this, who doesn't do it, but you know, I say in the workshops, this is not a big deal. You can learn these concepts in the workshops easy, no worry. And 5 minutes is enough for some of these surgeries, not to worry. Then I show them this video, and I'd like to show you the video to show you about the 5-minute concept of doing surgery. Just watch the sign on the door when it closes. Here we go.
Scalpel. Swell. Suction. Sponge. Swell. Clamp. Suture. Okay, I think we're done here. Scalpel.
5 minutes isn't ideal for everything.
5 minutes wasn't enough.
Keno, have to draw everything.
Go figure, huh? All right. Well, that, my friends, concludes the morning. Not at 12 o'clock, but it was never planned to end at 12 o'clock. But I kind of like this picture of the Perry building in San Francisco while we listen to the music from the Ohio State University marching band. I get it. Of course you do. So anyway, it's 12:15, and we're going to take a 45-minute break, which means, again, on the hour in whatever time zone you're in, 1 o'clock in my time zone, I'm going to sit down and start talking. Oh, there's another question I forgot about. Any workshops? Anthony. Hey, Anthony. Yeah. I had so many workshops scheduled for this year in March, April, and May that it was like the most I'd ever done. Just like that, they were wiped out. So then I was scheduled for workshops the first half of 2020. I was scheduled to the point for the first half, I was not taking any more dates. For workshops, lectures, anything. I was booked as much as I cared to be. Well, half of those are gone too. So I do have some workshops scheduled in March, April, I'm pretty sure in April, and I know in May, everywhere from Texas to Toronto, and I don't really remember every place. So there are several. If you're in Texas, I think I'm going to the dental school in San Antonio, but again, everything's up in the air. So yes, I've got workshops. Thank you for asking. If any of you doctors are looking for workshops, send me an email and I'll tell you what's scheduled, but we don't know if anything's going to happen. Michelle, any thoughts or comments?
No, we're just going to go ahead and we're going to take lunch for the next 45 minutes. Then we'll be, if you're okay with it, normally there'd be a 15-minute after the 45-minute break to kind of settle in, answer the poll question. Maybe on the break, they'll come, people will have questions that we may want to answer. And then we can, return back to the presentation.
I feel a little, we were ahead of schedule, but I somehow managed to fill up the time. So I'm back to 12:15. I can't promise you that 15 minutes will have no impact. It might. So maybe if people don't mind, they come back 5 minutes early to do the poll and get closer to 1 o'clock for start time.
Perfect. Yeah, that sounds good. I'll launch that 10 minutes before.
If you don't mind, I've got a break. We start back at 1. I've got a break schedule around 2:30, and we can always shorten the breaks. And it's so hard for me to be that precise, but I'd rather start back the presentation at 1, launch the thing a little bit early, and everybody could answer Michelle's survey a little before on the hour, and then we'll start on the hour, if you don't mind.
No, that's fantastic. I'll go ahead and I'll launch that quarter till. I'll launch the whole quarter till, and then that gives everybody plenty of time to get back.
Oh, cool. All right, you do that. And